चेक 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 चेक। ठीक है,
Good morning, everyone, and welcome, Gagan Kam. Welcome to this morning session of DOS teaching program. We will go ahead with the teaching program, even though we have less students, but we have to stick to the time because other speakers are to follow. So, without wasting much time, I would request Dr. Sandhya Makhija to kindly speak on USGB scan in posterior segment disorders.
Yeah, good morning everyone, and thank you, Chair. First of all, I would like to welcome you all on the behalf of Delhi Ophthalmic Society for this DOS teaching, last day of DOS teaching program. Hope the previous 2 days were helpful to you all, and this had been a wonderful initiative with Delhi Ophthalmic Society and RP Center, and Professor Titial had been kind enough to have it for us. So, I begin my first talk. Good morning. I was given this topic in vitro retina imaging, so I thought this would be a very useful and practical topic for the students, and especially for the posterior segment people. You know, I would like to say there's so many problems in the vitreous. Sometimes you don't know what is happening there, and you want to have a non-invasive kind of imaging, and you can really have the view, you know, for follow-up prognosis, and how do you want to plan your things further. You want to plan for surgery, or you plan for whatever and however you plan, and I will just show you some good images. And the main thing I will, I will tell you in between, on the way, that how the posterior segment or the ophthalmologist himself, like if you're doing this imaging yourself, and how does it add to your this thing. So just starting with basic principles, it is a pulse echo technique. Pulses of ultrasound waves are emitted and echoes produced by the acoustic interfaces, and returning signals are detected, which are amplified and displayed on whatever monitor. Uses can be both diagnostics and therapeutics. It is a non-invasive investigation of choice, especially in opaque media. Now, to highlight, high frequency in the range of 8 to 10 megahertz, and mind you, UBM is up to 50 megahertz. Whereas abdominal ultrasound is in the range of 1 to 5 megahertz. So this you should all know, that you know this ophthalmic ultrasound is in the range of 8 to 10 megahertz. Okay. There are various modes: A scan, B, C, D, M. Lots of other new scans have come up, and as and when you will see, as and when you start doing it yourself, or maybe you assist your senior people, then you will see. The various techniques: contact, immersion, various kinds of examination, topographic, kinetic, holographic, biomicroscopy, Dopplers, etc., etc. Then these days are 3D ultrasound imaging also, which is composed by obtaining partially overlapping scans and 3D compounding of B-scan ultrasound images. So this is the kind of probe, and they can be, the designs can be little variable. Sometimes it can be little more broader also, but by and large this is this, so that it confines very nicely over the lids. It has a small contact area. It's curvilinear, little curvilinear. It has a piezoelectric crystal, and there's a marker. You know, you see this marker that represents the top of the screen. So wherever you keep it on the top, you would know that okay, this is from the scan line is from top, coming from top to bottom. It can be done through lids or even directly over the sclera also. Essentially, the technique is done by the clinician and ophthalmologist himself, and this is the thing I was, trying to emphasize, to have a better clinical correlation of whatever you have in mind. Insist on having a combined A scan. I will show you pictures also where you have combined A scan spikes, and basic screening of entire globe to begin with, so that you get an orientation of the probe according to the lesion that you have in mind. Localize the lesion, quadrant, extent, position details, and other things. This is the kind of a normal anatomy. The posterior vitreous cavity is by and large anechoic. There is a dense echogenic retroorbital space, and in between there is a shadow of the disc, optic nerve head, and anterior segment. Amongst the anterior segment structure, you can just see the shine of the posterior capsule, and that is it. Nothing more than that. Vitreous is relatively equilucent in young adults. Low refractive vitreous echoes due to syneresis may be seen in, as the patient gets older. Uh, Now the things we can catch are PVD, asteroid hyalosis, vitreous hemorrhage. Echogenic pattern depends on duration and severity, and you have to look for echo density, membranes, any movements, any tractions or any detachments, and try to localize the cause of hemorrhage, like a tear or trauma, any trauma line or any proliferations maybe. So these are the various stages, or I would say various kinds of vitreous hemorrhage. I won't say stages. This first image is maybe a fresh vitreous hemorrhage with just scattered echolucent pattern all over. This is where it gets little organized. You can see some little membranes here. This is vitreous hemorrhage causing traction. You can see this traction pull, here. And this is whole vitreous hemorrhage, and these are the retinal echos. So this is vitreous hemorrhage with RD. Now I was talking that A scan corresponding A scan spikes. You see, these are the corresponding A scan spikes, and if you're going to buy a machine, it's always better if you have that corresponding A scan spikes, because it gives lots of extra information to you. So you see these dense scattered, sorry, not very dense, but scattered echogenic echos, and the A scan corresponding spikes are medium to low. As in when it gets more organized and you have some membranes, this is the line where this A scan spikes are seen, and you can change these lines, tangentially, or wherever lesion you want to pinpoint. And here the spikes start getting higher. Wherever there is a traction, the A scan spike is so high, and now the retinal membranes, the corresponding, this is intersecting here, and you see this corresponding A scan spike. This is a PVD, a thin undulating membrane. It could be a partial or complete, and again it's on the basis of what scan and what section you are taking. Here you can see, okay, sorry. Okay, here, my pointer is not working very well. Okay, here you see the PVD section is like this, whereas here you see the PVD section is like this. So it's on the, depending on the orientation of your probe. This is actually a video, so if it's not working, I'll show you in the end. This is a kinetic sonography, where you ask the patient to do some eye movements, right, left or something, and this undulating membrane, it moves. I think it's not integrated here. I'll just show you this short half-a-second video in the end. So retina choroid, what do you see? Retinal detachment, they are highly reflective. Fresh RD is relatively mobile, and old RD with PVR is a little stiff with funnel configuration. It may extend from ora till optic nerve in total RD. Look for tractions, membranes, tear, flaps, PVD, hemorrhage, and you have to differentiate from cases. Choroidal detachment are more smooth, more thick, dome shaped, usually located peripherally. Double spike, A scan, highly reflective but less so than retinal interface spike, and virtually no movements. So these are the kinds of pictures I was just telling you. This is a retinal detachment with high A spike, and this is choroidal detachment, double shaped, M shaped or dome shaped, whatever you may call. The spike is again high but little less than these retinal spikes. This is a combined choroidal. Again, this video also I'll show you in the end. Intraocular tumors, ultrasonography is a very good investigation for diagnosis and more for follow-up and prognosis. The main thing you have to look for is positions, shape, size, extent, internal echos, reflectivity, surface margins, base, sound attenuation behind the lesion, vascularity, and vitreous hemorrhage or vitreous spread or any other detachment associated. So this is a melanoma, huge dome-shaped internal echos, full. This is hemangioma, little flat. You may see some high echogenic surface on the top, and moderate echos in between in the center. These are the metastases, again flat but little away from the center of the globe. A retinoblastoma, where you see internal necrosis and calcifications, and scattered depending on the lesion and the site and position. Foreign bodies, again it is the investigation of choice. Intraocular foreign bodies I'm talking about. Now the A scan spikes are very high, 100% reflectivity with shadowing, and even if you reduce the gain, the A scan spikes more or less remain almost 100%. Look for a foreign body tract and other associated pathologies due to trauma. So this is intraocular foreign body. So this is the foreign body, and you see the tract behind it, and even the perforation or whatever from where it has come, those tracks, shadows are also there. And this is the corresponding A scan spike, which is 100%. And this is after you reduce the gain. I mean to say, whatever the reflected echoes are coming back to the probe, those are caught, and that is the gain basically. So even after reducing the gain, you stop seeing the other surrounding structure, but this foreign body is still highlighted. And I think where I've cropped the image, the A scan spike has probably got cropped, but you see this corresponding A scan spike still remain almost 100% after reducing gain. Other spikes go down. So this is another intraocular foreign body. Actually, this is a dislocated IOL, which is actually a kind of a foreign body only. Intravitreal cysticercosis, where you see that internal scolex very nicely, the whole cyst is there. And again, probably this video is not working. The cyst moves very nicely, and the scolex, the movement and all is seen very nicely in B scans. This is a patient with intraocular silicone oil. As we all know that silicone oil, reduces the velocity of sound waves. So apparently the eyeball looks longer, and it's very difficult to pinpoint what is happening, whether there is a detachment, because the echoes, the coming back echoes, are not very well seen. Sometimes you can pick up macular degeneration if there's a big macular degeneration on B scan also. But I mean, these were previous days when we didn't have good OCTs. We didn't have OCTs at all actually when we were doing our retina practice. So, but these days OCTs obviously are best. But sometimes where the media doesn't permit an OCT, you can pick up on ultrasound also. There are other indications other than probably posterior segment pathologies. This is the list, but probably, as per my topic, I will stick to only posterior segment problems. So in the end, I would just like to say ultrasound is easy, handy, and vital tool for ophthalmic diagnosis. It could be done as an OPD procedure, but more importantly, done by the VR surgeon himself. So I just half a second video. I don't know how to close this. Okay. नहीं सेव नहीं किया था. Okay, so this is kinetic sonography, where you ask the patient to you're putting the probe over the eye is closed, and then you ask the patient ke right left dekho, and then you see these undulating free movements. So this is a PVD. Don't think that this is a detachment or this is a retinal detachment shadows. So next video, क्यों move कर रहे हैं वहाँ से? Okay, so now this is a detachment. Okay, this you see it's not moving as freely as the previous one, and there's an underlying choroidal detachment also, which is so thick and stiff, and that is not moving at all. Whereas that retinal surface is showing little movement. Thank you.
Thank you, Sandhya, for your excellent presentation regarding B scan. Like few important things to remember in B scan. One is the hertz, how much hertz is used, because initially it was involved in PNDT Act also, so society has to fight a lot, because with this probe we can't do any abdominal scan. So one should know the hertz. Second, the marker tell you the anatomical orientation of the B scan. And thirdly, the A scan on B scan. So as Dr. Sandhya has explained so well, if the spike is more than half of your posterior highest spike, then it is the retina. If it is not, is less than half, so it is more of a vitreous cavity or anything else. Any questions? And Dr. Sarita, please, for special comment.
I think very good pictures Dr. Sandhya has shown. Thank you.
Thank
And
you.
I would say, like, when you put the probe, you should be very careful how you're putting it. You can even localize all the lesions.
Yes.
So thank
Any
you.
questions from the students, residents? We'll be happy to answer. Or maybe we can have the discussions later on.
You can write down your questions, and later on also you can ask. So we go on to our next speaker.
Thank you.
Next speaker, yeah.
I'm happy to
Siddharth
introduce Dr.
Madam.
Siddharth. He's an assistant professor in Guru Nanak Eye Center. He will be talking on uveitis and overview.
So uveitis is one of the very important subject, not to miss the diagnosis, because all treatment same, changes your treatment part.
I will first like to thank DOS and Dr. RP Center for giving me the opportunity to present this talk. It's a very large topic, huge topic, but I would like to summarize it in 10 minutes. Uveitis, as we all know, is the inflammation of the uvea. About 30% of the cases are idiopathic, but the remaining 70%, they are constituted by 30 separate disease entities, which could be infectious, non-infectious, autoimmune, autoinflammatory, or neoplastic masquerades. Anterior uveitis is the most common variety we all know, about 70 to 80% cases, followed by panuveitis, posterior uveitis, and intermediate uveitis. So whenever a patient with uveitis comes to us, we have to take a comprehensive ophthalmic and medical history. We have to evaluate their symptoms, see their signs. We have to assess and grade the severity of the uveitis at presentation. We have to see whether it's a healed or active uveitis, whether it's infectious or non-infectious. We have to always arrive at a morphological diagnosis. We have to assess for any accompanying structural complications like accompanying CME or a CNVM. Comprehensive medical examination is mandatory, and then we come to a differential diagnosis. The laboratory investigations are directed from patient to patient. We should always exclude infectious etiology, and treatment plan can be based on the type of etiology. Whether it's infectious, we institute antimicrobial therapy. Whether the steroid or steroid sparing agents have to be started as a first line, we have to assess the treatment and monitor side effects and toxicity. So once we come to look on for the differential diagnosis, we should first see whether what is the anatomic location of the lesion, what is the presenting features, the course of the lesion, the laterality of the eye involvement, lesion morphology, location, number. We have to look for whether it's primarily ocular disease or there's other systemic features which are counting for the presenting features in that patient. We have to see for the demographic profile of the patient, because there may be differences based on race and age. So standardization of uveitis nomenclature has given the anatomical classification of uveitis, categorizing into anterior, intermediate, posterior, and panuveitis, which primarily involve the anterior chamber, vitreous. For posterior uveitis, we have to have a documented lesion in the retina or choroid, and panuveitis, which involves all the three segments. So this is just an illustration to show that a patient who presents with acute anterior uveitis may have fine KPs and a ciliary congestion, as in the second picture also, and may have a very severe involvement in the form of progressive outer retinal necrosis as caused by VZV or a CMV retinitis. There's an expanded anatomical classification of uveitis where they've included keratouveitis, sclerouveitis, and retinal vasculitis. So in keratouveitis, mostly the cause is herpetic unless proven otherwise. In sclerouveitis, you look for the systemic cause for vasculitis, and so is for retinal vasculitis, whether it's chiefly arterial involving, venous involving, and whether it's primary or secondary. Now this is a tabulated depiction where you can see the most common causes of uveitis we come across in the OPDs. So CMV, herpes, and varicella zoster, they are very important causes of anterior uveitis. To point to be noted is syphilis, tuberculosis, and Lyme's disease. They are constituting the very important causes of panuveitis. So all patients with anterior, posterior, intermediate, you must look for these three diseases. Lyme's not very common, but we have to see in patients when they are not responding to the treatment we administer. HLA-B27 uveitis and Fuchs uveitis syndrome, they are important causes of non-granulomatous uveitis, and there are various multiple evanescent the posterior segment inflammatory conditions, which are the white dot syndromes. They are very important causes of posterior uveitis. So Sun working group has divided uveitis based on the onset, whether it's sudden or insidious, whether it's acute when the onset is sudden and of limited duration of less than 3 months. It's a recurrent uveitis where in between the attacks the patient has period of inactivity, the eye doesn't show any inflammation for at least 3 months. These terms are not interchangeable. Many people interchange recurrent and chronic. However, in chronic uveitis, there is persistent inflammation with relapse within 3 months after discontinuation of treatment. So patient may present with a white eye or with a red eye which is painful, and presenting feature in patients of uveitis is usually a low IOP. However, patients like herpetic uveitis may have hypertensive uveitis at presentations. So we have to assess the anterior chamber inflammation based on the Sun classification. We have to grade it from grade 0 to grade 4. And where we can make out in a 1 by 1 mm slit beam of light, we have to grade that, count the number of cells and assess the flare. Uveitis is classified into granulomatous and non-granulomatous variety. Point to be noted is granulomatous uveitis, you have mutton fat KPs, and they are usually caused by conditions which are chronic. You may have changes in iris pattern, moth-eaten appearance, iris nodules. You can have new vascularization of the iris or posterior synechiae, which are responsible for miotic pupil or a festoon pupil on dilatation. Lens may show complicated cataract. You have vitreous segment involvement in the form of exudates, and you have secondary changes in the fundus in the form of cystoid macular edema. This list is given in all textbooks, so you can go and see the causes of granulomatous and non-granulomatous uveitis. As I mentioned, important causes of non-granulomatous uveitis includes HLA-B27 associated uveitis and Fuchs heterochromic uveitis, which is usually asymptomatic. Granulomatous uveitis is caused by the chronic conditions. Bilateral granulomatous uveitis is mostly caused by a condition which has a systemic origin, and that can be seen in VKH, sarcoidosis, syphilis. Sympathetic ophthalmia is another important cause of bilateral granulomatous uveitis. So I'll just quickly show you various pictures to have an overview how patients with uveitis, anterior uveitis, who are non-granulomatous in presentation present. So HLA-B27 patients who are seronegative for RA may have anterior uveitis. Patients with these are the various syndromes which come as a part of the HLA-B27 associated uveitis. So patients may have reactive arthritis, psoriatic arthritis. Behçet syndrome, important point to note is that you see a mobile hypopyon and the patient has a white eye on presentation, and it's an important cause of panuveitis. Patients with tubulointerstitial nephritis have bilateral non-granulomatous anterior uveitis, and definitive diagnosis based on a renal biopsy. Bauchner-Slosson syndrome is another important cause of hypertensive uveitis, where you have high intraocular pressure on presentation, and most important cause in these has been propagated to be CMV, and PCR in such cases is important. Fuchs, as I mentioned, is usually asymptomatic, so you have to look for very fine KPs. Patients who come with unilateral cataracts or glaucoma, the KPs have to be looked for in those cases. As I mentioned, herpes simplex is an important cause of hypertensive uveitis, where you have very high IOP at presentation, and it's usually a granulomatous uveitis. You can have sectoral iris atrophy. Tuberculosis can involve any structure of the eye, so you have to be very careful, and hypopyon is not very common, though patients may present with hypopyon and tuberculosis. Lens-induced uveitis is usually granulomatous. It could be because of the disruption of lens capsule or leakage of lens proteins. IOL-associated uveitis, most commonly in sulcus-placed IOLs or anterior chamber and iris-fixated IOLs. You can have patients who present with as severe as UGH syndrome. Another patient with chronic uveitis who lost vision, you can see band-shaped keratopathy. JIA is a very important cause in children, and the severity of uveitis is categorized based on the number of joints involved. So all children who come, you have to see this cause. So what I want to say is you have to come to a specific diagnosis. You have to confirm the clinical diagnosis based on your morphology. You commence anti-metabolite immunosuppressive therapy accordingly, and you have to identify the complications and what are the reasons the patient has poor vision. So as I mentioned, single episode of unilateral uveitis, non-granulomatous, you don't have to investigate. However, a patient who has recurrent severe bilateral anterior uveitis, you have to investigate for the conditions that we have mentioned. Intermediate uveitis will be covered by the subsequent speaker as mentioned, but just few pictures of the posterior uveitis. As in this patient of tuberculosis, you can see solitary choroidal granuloma or a diffuse choroidal infiltration in patients who are having immunosuppressed state. This is a patient of syphilis who has a maculopapular rash and has a diffuse placoid chorioretinitis type of lesions. This is a punched out chorioretinal scar, a retinochoroidal scar in a patient with toxoplasma, and it's a very important cause of low vision in children. So you have to see the fundus accordingly. The patients can have dense vitritis, retinitis, and toxoplasma. Toxocara can have patients who present with leukocoria, and these patients have choroidal granulomas which can extend into the vitreous. Sarcoidosis, as I mentioned, is an important cause of panuveitis. So you can have granulomatous uveitis. You can see iris nodules at the pupillary border in the angle. You can see snowballs, and such patients can have choroidal granulomas at presentation. So these patients need to be managed with the involvement of a pulmonologist. Bessett's disease, important cause of pan-uveitis. You can have very severe involvement, as severe as a necrotizing vasculitis, occlusive vasculitis. VKH, as I mentioned, is an important cause of bilateral granulomatous uveitis. You have to look for the systemic profile of the patient, and patients can have exudative RDs on presentation, so you have to do FFA and OCT for their diagnosis. Sympathetic ophthalmia is important, which follows following a penetrating trauma. White dot syndromes, as I mentioned, they are categorized based on the type of the choroidal spots that these patients present with. So they can have amoeboid spots, plecoid spots, or the yellow-orange spots, punched out spots in multifocal choroiditis with panuveitis, and multiple evanescent white dot syndrome. So just to summarize quickly, fungal we all know, this will be covered by the subsequent speaker. These are important causes of endogenous endophthalmitis. So these patients who are immunocompromised have to be worked up for these causes. Viral, as I mentioned, you have to see the patient's immune status and see for features of Kaposi sarcoma or anterior uveitis in patients with HIV. So as a carry home message, I would just want to say that we have to always make a morphological diagnosis of uveitis. What is its severity? We have to consider a masquerade like intraocular lymphomas. Patient may respond with steroids for a short while, but when they come with recalcitrant uveitis, you have to look for it. A dilated fundus examination is essential in any patient with disc swelling, or for that matter in any patient with uveitis. You should always rule out infective causes. Regular monitoring and close follow-up is important. Appropriate investigation should be done at the right time. You have to check for all investigation that a patient is carrying with him. Not that you miss out on few investigation. You check the patient's compliance to treatment. Counsel the patient about long-term management. You do not hesitate to take a second opinion. You have to pay attention to the subtle clues and look for the patient as a whole and not just the laboratory investigations. Thank you.
Thank you, Dr. Siddharth. It is really extensive and you covered it up at exactly in 10 minutes. And I must say that the maximum MCQs comes from uveitis, like hemorrhagic uveitis, uveitis with high pressures, because normally it has low pressure, snowballs. So all this is very important. Thank you.
So we have next talk by Dr. Amit Khosla. He's a renowned VR surgeon practicing at Gangaram Hospital. He's going to speak on intermediate uveitis.
Good morning, everybody. Intermediate uveitis is a diagnosis of exclusion. It's about 10% of the patients. So here's a patient who was referred across the country with this tractional detachment from ROP to FEVR to retinoblastoma, and came to me for a second opinion, and the angiogram showed that the drag. Now, this is a complication of long-standing intermediate uveitis. After 3 months of diagnosis of intermediate uveitis on Folitrex and adalimumab, the patient had 660 in the left eye and 669 in the right eye. So the enigma continues. How do you define? These are the two review articles from 1987 and 2006 in the American Journal of Ophthalmology. So it's a diagnosis of exclusion. You have vitritis, you have floaters, you have cells in the vitreous, you have CME, you have disc edema, and you have vasculitis. So which one of them is actually the diagnosis? So cells in the vitreous, right, is the classical diagnosis of intermediate uveitis. But you have other findings which may be in other types of uveitis also. So new classification of pars planitis is that it's idiopathic with snowballs and snowbanks. You can have, that is the non-pars planitis type. If you have a severe form, you may have the pars planitis type where you have, and the third one is with multiple sclerosis. In India, I think TB is a very big cause for intermediate uveitis. So I won't go into the details. You can look up the literature. You have these criteria where you have this criteria for classification of these three types of intermediate uveitis. The Sun classification 2005 tried to classify uveitis, and the Sun 2021, which I have just described, that now we call it the pars planitis type, the non-pars planitis type. So the side study confirmed the role of immunosuppression in chronic uveitis, and it said that the long-term risk of malignancy is not there in uveitis in all these immunosuppression. So all these years we were hesitant in using immunosuppressive because we had the risk of malignancy. Now we have the MUST trial which says that intraocular steroids on a long term are less effective than immunosuppressive over 7 years. So we are shifting from steroid posterior subtenons intraocular implants to immunosuppressive because the MUST trial shows that it's 7 years. And we have this latest guideline called the FOCUS guideline which came in 2020. You can read this up. if you are interested in uveitis. And now we have the role. So basically it's inflammation in the vitreous and the peripheral retina. We have various causes. You can go into the details. Floaters, decreased vision, or the patient may be just asymptomatic. Generally starts unilaterally, maybe bilateral. You can see these clumps in the vitreous. Snow banking at the pars plana in the severe or long-standing form. If you have pars planitis, you can think it's been there for a long time. You can see the active snow banks, and the ones it heals is a small fibrosis and traction at the which never disappears. So complication can be a ERM, CME, a retinoschisis because of traction, VPT, that's called vasoproliferative tumors which occur at the periphery, which you can have a pacified posterior hyaloid, you can have long-term chronic hypotonia, you have a tractional detachment. So our aim of treatment in intermediate uveitis is to prevent these complications. If you have a chronic patient, remember it will take 5 to 10 years to control, and you need to put the patient on immunosuppressive. So what is important? The duration, systemic features. MS is rare in India. I have seen 1 or 2 cases only. More of tuberculosis we see in India. Lyme's is not available in India. I just suspected one patient to have Lyme's. We don't have Lyme test in India. It has to be sent abroad. So Lyme is rarely seen in India. And you can think of other infections. So what do we do? In India, we do a Montour, quantiferon. I prefer to do a CT chest in all patients, serology for syphilis. There is theoretical serology for Lyme's. So basically, we are looking for sarcoid and TB in Indian population. And even HIV can sometimes cause. So we treat the underlying cause, but we don't find the cause in 2/3 of patients. So what do you want to do? Do you want to suppress the curve, or you want to treat it? So if you want to flatten the curve, short-term flattening will be posterior subtenon, intravenous, in oral steroids, or vitreal steroid. But if you want to do a long-term flattening of the curve, then you need to do IMT and biologicals, because every time you give a Ozodrex, you're going to have a rebound CME, long-term ERM. So you want to flatten the curve completely. So these drugs. Now we have this Kaplan. We always taught the Kaplan 4-step, but that was treatment without the modern tools. We didn't have things like wide field angiography or OCT. So now the treatment is different. You may see a interior uveitis with posterior synechia or spillover. So it's important that you do a posterior segment examination, all your interior uveitis, to rule out any posterior pathology. Or you may have a vitritis. So you rule out infections, toxocara or viral retinitis. You may have vision loss with floaters, do the OCT and FFA only. Or you have secondary complications. So you have these 4 scenarios where you see patient at a different time of the disease. The prognosis is good in adults, but if you have this long-term complication, you will have a vision loss. So our aim is in management is to prevent. It is something like hypertension, diabetes. You're treating an intermediate uveitis for long-term complications. The prognosis in children is poorer. You need day 1 immunosuppression in children with this thing. So the initial indications were that you treat only those patients with 20/40 over the macular edema and retinal vasculitis. No, you treat, and my aim of treatment is to have 6/6 vision, not to have 6/12. So initially you can try topical, periocular, intravitreal, depending on the case, and finally you go to immunosuppression or biologicals. Now vitrectomy is a last resort in such patients, because 99% of patients will get treated with these options. So remember that you have complication of every treatment which you should be aware about. So in a unilateral case, you may not want to give immunosuppression, you may want to just give local steroids, and you can supplement with systemic therapy when you have a poor response. So normally when you start with steroids, in 2 to 4 weeks, if you feel that disease is not controlled, you will require immunosuppression, because you don't want to give steroids for more than 3 months. So we have these 3 options of normally we use these drugs. Now only we use methotrexate, azathioprine, mycophenolate. We don't use this or this because we have other safer options. So you have biologics which give response much better than these, but the cost factor is limited. As the cost goes down, we'll have better. Now we are using JAK inhibitors, which are not as effective as biologics, like tofa and baricitinib, which are cheaper and oral. So a small mention about pediatric, that it will always require immunosuppression from day 1. So I'll just show you a few patients. Patient presented with disc edema in cells. So OCT gives you an idea. So it is not papilledema. Sometimes the intermediate uveitis is diagnosed as papilledema. You need to be careful. You see these snowbanks. You see the disc leakage in inflammatory disc edema. So as you treat, and I always do if you have a doubt about say quantiform or TB, you do a PET scan. You sometimes pick up a lymph node in the axilla or in the abdomen, which you can biopsy, and you can find out it is TB or sarcoid. So here the patient with long-term treatment has resolved, has good vision, and the disc edema also comes down. So you don't need to do FA. The OCT helps. So here's a patient who had a mediastinal lymph node, was referred to us with fever, and these are the classical pictures. And the patient was diagnosed sarcoid, and we added MMF. The patient had 6/6 vision. So you're looking for a resolution over months, not weeks. Here's a patient who presented to us late, who had pars planitis, who had membranes. So patient was having 6/6. So why would you give biologicals in a 6/6 vision? Because you don't want this complication to occur. So even with 6/6 and a peripheral traction, you have to give immunosuppression. So in 1/3 of children, this is a patient in April 2020, thanks Dr. Rohan Chawla, who does the wide field for me. And you see that the membrane has fibrosed, and this is limited to the 1 point. But activity still continues. So we used to feel that, the intermediate uveitis, no CME, no student edema, but the peripheral leakage will continue in zone 3. So there's a debate whether you should treat these patients or you should just monitor. But I feel that in children, long-term complications will occur if you have even a zone 3 activity. So you need to be more aggressive. Here's another patient. So you keep adding drugs, and gradually the disc edema, the CME disappears. So what you're looking in management is you look for disc edema, you look for CME, and you look for the peripheral traction. So peripheral traction is a big risk factor long term. Here's a patient who came with extensive vitreous membrane snow banking vitroschisis on oral steroids, has leakage. Patient, there was a small hole which is lasered, and it is another last case 7 with snow banking. So you can see the snow banking reduces with time. So most important is that in intermediate uveitis, don't fear immunosuppression, treat all patients and look for a 5 to 10 years horizon, which helps better management. Thank you so much.
Thank you, Dr. Amit, for your excellent presentation. Dr. Amit, beside being a great vitreoretinal surgeon, he has a specialized work in uveitis. So it's very important to diagnose the cases of the uveitis and educate your patient for the recurrent attacks, how to identify and get it treated as early as possible. Now Dr. Sanjay Mishra, he is a head of the department of RR hospital. So he is a great vitreoretinal surgeon. Today he will be presenting on macular hole.
Thank you, DOS and RP Center for giving this opportunity to me. So I'm going to speak on macular hole, which is a very important topic as far as postgraduates are concerned, because invariably either you'll get a case or you'll be asked an examination about viva, table viva, but definitely one question will be there from macular hole. For definition, we know that's a full thickness neurosensory retinal defect at macula. Usually it is surrounded by localized and neurosensory retinal detachment. That's a cuff of fluid around the macular hole. If we go in the history, we see that first time it was described by Knapp in 1869, and Kelly and Wendell were the first to use surgery for macular hole. But the most important diagnostic invention came from Gass and Johnson in 1988, who described the classification of macular hole. As prevalence, it's around 3.3 cases per 1,000. It is more when you grow in the age, that is more than 70 years, and there is a preponderance in females. Etiology, we know 80% of the macular holes is idiopathic. Traumatic is a very important cause. It causes less than 10% of macular holes, and other miscellaneous causes are important because we have a lot of cases of myopia, and all those progressive myopias, we can have macular holes. Cystoid macular edema after laser treatment, secondary to ERM, and when you do a retinal detachment repair, you can have a macular hole in that. The pathogenesis, role of trauma is very, very important. Again, role of estrogen is important because it is more prevalent in ladies. Macular cyst, we can see those macular cysts when they coalesce, and they can open up and form, degenerate over a period of time and cause macular holes. The most important factor, which is the persistent vitreous attachment to the macula. This is very important causative factor for the macular hole formation. 53% of macular holes happen without PVD. So when the PVD happens, it leads to a complete full thickness macular hole. Gass and Johnson 1988 described the formation of macular hole in various stages. That is, there is a focal contraction in the prefoveolar vitreous cortex, which leads to a tangential traction on the fovea. There is a foveolar detachment, and which causes the macular hole. This is the chart which is normally given in all book. You must read about this chart, how the macular hole progresses from stage 1. In fact, stage 0 has been also described for the macular hole, from stage 1, which is an occult macular hole, to a stage 4, which is a full thickness macular hole. 60% spontaneous vitreofoveal separation can lead to a relief of retinal traction, and in early stages of macular hole, that is in stage 1 up to stage 1 and early stage 2, you can have resolution of macular hole when the detachment, the foveal detachment is complete. This is how the Smitty and Finn hypothesis in 2004, they suggested that there's an early cystic degeneration in the inner retinal layers. There's a wound healing by the glial and motile cells, which leads to a tangential traction around the fovea. Later on, it is proved that apart from tangential traction, it is the anteroposterior, that is a perpendicular traction at the fovea, which is very, very important causation of the macular hole, which is described in the OCT. Where the OCT was found, they have described on OCT what type of tractions is seen. This is what is seen, that there is a repair by the glial cells and can lead to formation of the This is the OCT. You can do an autofluorescence. You can, on the left side is the autofluorescence. You can see this. There's a fluorescence on the macular hole side. On the right hand side, there's a angiography. You can see the defect, RP defect, and that leads to a early hyperfluorescence. This is the 3 diagnostic investigation. That is, the lowermost is the OCT, which is the most important of the diagnosis of macular hole. Gass and Johnson described the classification, which is the most commonly classification which we use, and all postgraduates should know, because they will be definitely asked about the classification. When you say the diagnosis of macular hole, you are supposed to say about the classification, which starts with 1A and 1B. 1A is the earliest form of macular hole, which is the foveolar detachment. The vitreous which is attached to the fovea and pulls the fovea. The inner retinal layer remains intact, but the outer retinal layer, there's a detachment of the IS-OS junction, and that leads to a sign which is known as a yellow spot. Then comes 1B. There is the detachment becomes little more pronounced apart from the fovea. Then the fovea gets detached, which forms the yellow ring. These two are usually missed out diagnosis, because we have to see very carefully these clinically also, and that's when you do an OCT, you can see those findings. So this is known as the occult macular hole stage. Then comes the stage 2, which is the full thickness. There is no PVD in that, and when you see the pathological findings, you see an eccentric can opener or a central macular hole which is less than 400 micron. Stage 3 and stage 4 are same. Stage 3 is more than 400 micron macular hole with an operculum. Operculum is important because this is could be a pseudo operculum, or because you are asked in examination what is a pseudo operculum and what is a true operculum. So pseudo operculum is there is no structure of retina which is available. It's just thickening of the glial cells in the prefoveolar region. And operculum, a true operculum, is a part of the retina, that is a fovea, is attached to the prognosis of pseudo operculum is much better, because there is no loss of the foveal tissue, and in pseudo operculum, in the true operculum there is a loss, so the prognosis is not that good. And in this stage 4, there is a complete vitreous detachment, which is not only detached from the fovea but also from the disc, so you can see the V's ring present in these cases. This is how the diagrammatic representation from the OCT, you can see the clinically also, and the OCT diagnosis of stage 1 to stage 4. How do you diagnose clinically the patient? How the patient comes with metamorphopsia and loss of central vision. Visual acuity, depending upon the stage of the macular hole, will vary from 6.6 to less than 4/60, depending upon the stage, and also the duration of macular hole. Very, very, very important to ask the history, because ultimately the prognosis of macular hole depends on the duration of the macular hole. The natural history is very, very important to know, because patient, when you go and practice clinically, you will be asked, when you see a stage 1, 50% of the macular hole regresses and 10% stabilize, only 40% progress. So stage 1 is the place where you can wait and watch. These holes can definitely go back and repair, especially if there's a history of trauma. Stage 2, 15 to 25%, 20% regress and 75% progress. So beyond stage 2, one has to offer surgery. That surgery is the only treatment of choice in these cases. And stage 4, 20% they further enlarge. You diagnose it. The most important diagnosis is clinically you do a biomicroscopy with 90D lenses. After dilatation, do focus on the retina and you will see the macular hole clinically. Watsky-Allen sign is which is described by the patient. Laser aiming being Amsler-Gret, FFA and OCT. You can do a red-free imaging of the macular hole and you can see those. Also look for the PVD. This is what is the yellow spot. This you can't see much, but you can see the yellow ring in this stage 1B. This stage 2, stage 3 and stage 4 look alike except for the PVD. This is a red-free photograph. Surrounding cover fluid is very, very important in these cases. Type of yellowish, you can see a typical yellowish granular deposits on the retinal pigment epithelium in 50% of the cases. Watsky-Allen sign is, as I told, it's a subjective sign. You make the thinnest slit beam because it is more for a examination point of view, because you will be asked what is Watsky-Allen sign. You make a thinnest slit beam projected over the macula, and patient describes or better he draws what he sees. In a macular hole, you can see that in the center there is a gap in the slit. So that's what is the description of a macular hole. Amsler-Gret can tell you about the absolute or the relative central scotoma. Laser aiming test is also it's very common and you can do easily, and that can also help you in diagnosis of macular hole. You do an FFA, you see an early hyperfluorescence and with a late fading. This is how it appears on an FFA. You can see there's a early hyperfluorescence because of the defect, AP defect. OCT is the gold standard. So most commonly we all jump to OCT and you use this diagnostic tool. And there is based on OCT also there's multiple classification of OCT. I'm not going to go into the classification, but you must know the OCT classification of macular hole, because it is very, very important. Not only from theory point of view, but also from the examination point of view. So this is. So this is 1A. I've already mentioned about this. These are the various. So differential diagnosis you must know. VMT, cystoid macular edema, CSR, solar maculopathy, pseudorepiculum, central drusen, vitelliform dystrophy, and inflammatory maculopathy. You should also know the pre-macular hole lesions like epiretinal membrane with pseudomacular hole formation, lamellar macular holes, and chronic cystoid macular edema. Management is important because in table viva, when you are given, you are usually asked how to manage a case of a macular hole. Stage 1, there is no significant difference between vitrectomy and observation, so one can wait in stage 1, as I told you earlier. Stage 2 and beyond, definitely they progress to a full thickness macular hole, and you require a vitrectomy in these cases. Standard surgery, standard procedure is a 3-port vitrectomy, removal of a posterior hyaloid face. I'll just show you the surgical video of this. So this is how it is. You do a 3-port pars vitrectomy. You stain the vitreous with triamcinolone and do a PVD. PVD is very important too. In case if it's a stage 4, the PVD is already existing. In case it is not there, one must induce a PVD and stain the internal membrane with a brilliant blue dye. Other dyes which can be used for staining is an ICG and trypan blue. But nowadays we use brilliant blue green, and it stains well the interlimiting membrane. You do a ILM peeling, wider ILM peelings to relieve the traction, and after ILM peeling is done, you do a fluid air exchange and give a tamponade with a gas. One can use an air or gas, preferably it is gas. The other types of gas like C3, F8 and SF6 are used. You use a non-expansile combination of these gases, because if you use a expansile combination, it can expand and cause a rise in the IOP. And there are very two things important after, it is normally what is asked, and I ask my ask my students, that what are the two most important precautions or instructions you tell your patients after a vitrectomy, especially for macular hole surgeries. Two things. One is face down position, which is not nowadays, it's debatable, but definitely 1 to 3 days is required to give a tamponade on the macular hole. And second is to tell the patient, warn the patients that your vision will be blurred because of the gas for 6 weeks. So don't expect that next day you have a good vision and the patient is walking. So you have to tell. And secondly, watch for the IOP and avoid air travel, because this is very, very important instructions. You must know, and you will be asked in examination of this. So what are the complications? You can have a nitrogenic break, 3 to 22% cases. You can have a progression of cataract if the patient is not pseudophakic. We normally do a cataract surgery along with macular hole surgeries. That complication is always there, because 32 to 76% patients do get cataract formation. You can have an RD, raised IOP, and late complications like field defects you can have. So fellow eye is always at risk. You must examine the fellow eye. PVD, if there's a PVD which has happened, there is no risk. If there's a partial PVD or attached vitreous, there's a high risk in these cases. Thank you.
Thank you, Dr. Mishra. That was very well covered. It's a huge topic covered in 10 minutes. Any questions? I think.
Yes. Recently, I was reading somewhere, somebody graded macular hole closure.
Yes.
And the normal macular hole closure, you have 1, 2. It's graded 1, 2, 3. So, any idea about? Because I couldn't find the reference anywhere.
I did a lot of search yesterday, so I only mentioned 1, 2, and then other thing is that OCT classification of it.
Yeah,
The
so
third part is,
yes, and that was a very unusual thing. It was grading according to ISOS junction closed.
Yeah, yes, sir.
ELN closed, and the normal grade 2. So that's why I was just wondering whether you have any reference to it.
No,
I couldn't find the
I couldn't. I was doing a search yesterday, so, but I couldn't find one. So normally you are asked what the type of closure. That's important to know, because sir has told about this closure. You should know about two closure: type 1 closure and type 2 closure. So this is important. The type 1 closure, there is no neurosensory defect in the closure. That means its normal anatomy is restored. In type 2, there is a defect in the foveal region. The hole closes, but there's a defect, so it's a type 2 closure. Type 2 closure usually happens in a larger macular hole, and type 1 is the preferable type of surgery. You want to see a type 1 closure, but you can have a type 2 closure also preferably if there's a large macular hole.
Thank you, everyone. So for the next talk, I would like to invite Dr. Ashish Markan. I think he'll be talking on a very important topic, which is retinal detachment, etiopathogenesis, types and documentation. I think this is one of the most important questions that as far as retina is concerned, I suppose. And Dr. Ashish is a VR surgeon with I7 Group of Hospitals, and he'll be enlightening us on this topic. Thank you.
Very good morning to all. So I'll be talking about the etiopathogenesis, type and documentation of retinal detachment. As we all know, retinal detachment refers to the separation of the neurosensory retina from the underlying RPE. Until the early 1900s, retinal detachment was a blinding disorder with unclear pathogenesis. It was thought to be an exudative process occurring from choroidal leakage and not caused by retinal breaks. The early treatment involved instrumentation to produce tears in order to allow for the subretinal fluid to egress into the vitreous cavity. So it was until 1920 that Jules Gonin told all of us that it is actually the regma or the retinal breaks which causes retinal detachment. So the retinal detachment which is caused due to the presence of a regma is known as regmatogenous retinal detachment. The ones where there is traction or there is proliferative membranes which is causing the elevation of the retina is known as the tractional retinal detachment. And one where there are no breaks, there is no traction, but there is exudation of the fluid due to an underlying choroidal or a retinal pathology is known as exudative retinal detachment. So regmatogenous retinal detachment is the most common form of retinal detachment, occurring in approximately 1 in 10,000 of the population. So this is a patient who presented with a total rhegmatogenous retinal detachment. He had this supratemporal horseshoe tear, and this is how classically a rhegmatogenous retinal detachment looks like. It will have a bullous configuration, will have a convex configuration with these wrinkling on the retinal surface. So how does the retina detach? So for retinal detachment to happen, you need to have vitreous liquefaction, you need to have a full thickness retinal break, and you need to have a traction at the edge of the break. So the break could either be a horseshoe tear, it could be an operculated hole, or it could be retinal dialysis. So retinal detachment could either be a total retinal detachment, could be a subtotal retinal detachment. It could be a subclinical retinal detachment, which refers to subretinal fluid which extends more than 1 disc diameter from the break but is less than 2 disc diameters posterior to the equator. And if the subretinal fluid extends less than 1 disc diameter, the condition is defined as a retinal break without detachment. So the upper image is a patient of a total retinal detachment who had a detachment due to acute retinal necrosis and underwent a pars plana vitrectomy. This is another patient who had a subtotal retinal detachment. There was a lattice degeneration with a horseshoe tear at its edge, and I performed a pneumatic retinopexy with a successful anatomical outcome. So what are the risk factors for a retinal detachment? So it could be various peripheral retinal degenerations like lattice degeneration, snail track degeneration, degenerative retinoschisis, tractional tufts, and white without pressure areas, especially if it has caused a giant retinal tear in the other eye. Other risk factors are the peripheral retinal breaks, axial myopia, previous intraocular surgery which can induce anomalous PVD, trauma, previous retinal detachment in the other eye, family history of retinal detachment, genetic disorders like Marfan syndrome, Stickler syndrome, which tend to have a degenerated vitreous and extensive peripheral retinal degenerations, presence of acute retinal necrosis or CMV retinitis, and if we perform YAG cap for a posterior capsular opacification, that also increases the risk of retinal detachment. So whenever we are examining a case of retinal detachment, we need to perform a binocular indirect ophthalmoscopy. We need to identify the extent of retinal detachment, find all the breaks which will help guide the surgical approach, determine whether the retinal detachment is macula on or macula off, check for associated features like presence of PVR changes, choroidal detachment, hemorrhage, epiretinal membrane, etc., and document your findings on an Amsler-Dubois chart. If the view is not clear, in those cases you can actually go ahead with an ultrasonography, and this has already been discussed that how do you differentiate between a retinal detachment and a posterior vitreous detachment. So if you see, this will be a high, it will be high, the membrane will have a high reflectivity, but as soon as you decrease the gain, if it is a retinal detachment, the membrane will still persist, whereas in cases of posterior vitreous detachment, the membrane will disappear. And also you look for after movements. So how do you perform these after movements? You ask the patient to look in various directions, and if it is a retinal detachment, it will have a poor after movements, whereas a PVD will have a good after movements. And now once you have seen the retinal detachment, you have you have basically known the extent of retinal detachment. The next thing is to find the rhegma. And how do you do that? So there are various Linkoff rules. The first one states that if it is a supratemporal or a supranasal detachment, in 98% of cases, the primary break lies within 1.5 clock hours of the highest border. If it is a total detachment or a superior detachment that crosses the 12 o'clock meridian, so in majority of the cases, the break will lie within a triangle, the apex of which lies at the ora serrata, and the sides of which extend 1.5 clock hours on the either side of 12 o'clock. If it is an inferior detachment, so in 95% of cases, the higher side of the detachment indicates on which side of the disc the inferior break lies. But if the detachment has the height which is equal on both the sides, probably the break lies at 6 o'clock. And if it is an inferior bullous detachment, then the break usually is present superiorly and the fluid usually tracks down along the ora serrata to cause an inferior bullous detachment. And once you have seen all these findings, it is important to document these findings using a standardized color coding. So retinal detachment is drawn as blue, an attached retina is drawn as red. Anything which is there in the vitreous cavity is drawn as green. Anything on the retinal surface is drawn as green, like an epiretinal membrane. Anything which is below the retinal surface is drawn as yellow. Choroidal detachment is drawn as brown. So there are these various findings you must know. Also, how do you draw these PVR contractions? So if it is a type 1 contraction, which is known as a focal contraction, you just draw a single cross. So there are different ways you need to draw them. So these are some of the diagrams which I drew when I was a resident. I just thought I'll put them in my presentation today. This is the case of a subtotal retinal detachment. And this is how you draw retinoschisis. So it is usually drawn as a blue with crisscross pattern. So now coming on to the tractional detachment. So there are various causes. It could be proliferative diabetic retinopathy, retinal vein occlusions, vasculitis, sickle cell retinopathy. In children, the most common causes are the ROP, FEVR, persistent fetal vasculature, toxoplasma, toxocara retinitis. So this is a patient who came a couple of days back, had a bilateral diabetic tractional detachment, and you can see that this is an extensive fibrovascular proliferation with an overlying pre-retinal hemorrhage. So this is important. How do you differentiate between a TRD threatening macula and a TRD involving macula? So a retinal elevation which is at least 4 disc areas, some part of which is within the 30 degrees of the center of the macula, is known as TRD threatening macula. Also, if the elevation is less than 4 disc areas but has an associated vitreoretinal adhesions causing elevation of the retina within 30 degrees of the center of the macula, or has a presence of new vessels or fresh vitreous hemorrhage, again is called as a TRD threatening macula. Whereas a TRD involving macula is a traction along the arcade at the disc, or if the traction lines are extending through the fovea and causing the vision loss. Now, whenever you're evaluating a case of tractional detachment, you need to do a detailed slit lamp biomicroscopy, a fundus examination, fundus photo, fluorescein angiography if possible, and an OCT scan through the macula. You must look at the ocular alignment because most of these cases, majority of these cases can have an sensory exotropia if they have a long-standing TRD. Look at the projection of rays, presence of pupillary reaction, and also look at the anterior segment in an undilated state to look for any NVIs or NVAs. You need to exactly localize the fibrovascular membranes, the neovascular tufts, know the extent of the tractional detachment. If there is presence of any subretinal bands, presence of any pre-retinal subretinal bleed should also be noted in your preoperative workup. Now, there's an important role of OCT imaging in TRD. It will help you assess the level and severity of the membranes. Also, it will provide you the clue regarding the location of the potential space where the safe dissection or the initiation of the membrane removal can be performed. Also, it is important to perform a foveal scan, look at the foveal status, whether there is presence of any epiretinal membrane, vitreomacular traction, any cystoid macular edema, subfoveal fluid, retinoschisis, because all of these things will help you prognosticate the case. So this is a patient who presented to me a couple of months back, had a bilateral tractional detachment along the arcades. The scan in the right eye showed a relatively good foveal architecture, whereas in the left eye, there was presence of this subfoveal fluid. So I decided to operate in the left eye first, and the patient had an excellent visual as well as structural outcome. Lastly, the last topic is the exudative retinal detachment. So there's no break, there's no traction, and this is basically the disruption of the blood retinal barrier. It could be multifactorial in origin, and most of these patients can be managed medically. The list is quite extensive. The ones which we see clinically, mostly in our clinical practice, are the inflammatory causes like VKH, sympathetic ophthalmia, posterior scleritis, Behçet's disease. In infectious causes, normally we see tubercular granulomas, which can actually exudate the fluid into the subretinal space. Choroidal pathologies like melanomas, osteomas, hemangiomas, lymphomas, all of them can present as exudative RDs. Similarly, Coats disease, VPTs, astrocytic hematomas, and some miscellaneous causes like CSR, uveal effusion syndrome, and even bilateral dump syndrome, they can be presenting as exudative retinal detachment. So I'll be showing few images of my patient. This was a patient who had lung cancer and presented to us with exudative detachment in both the eyes. This is another patient, a young patient of VKH, had an inferior exudative RD, and on OCT you can clearly see there are cells in the vitreous cavity. There is diffuse choroidal effacement and presence of an exudative detachment. This is a patient of uveal effusion syndrome, had an inferior exudative RD, and clearly you can see a leopard skin appearance on fluorescein angiography. This is a young patient, again had a nasal melanoma. He was totally asymptomatic and had an overlying exudative detachment. This is a patient of cysticercosis, again presented with an intraocular cysticercosis with an overlying exudative detachment. Just a minute. Yeah, thank you. So this is the last slide, just because we've already discussed most part of it. So this is how you differentiate between a regma, a traction, and an exudative RD. So there will be presence of a retinal break in a majority of the cases of regmatogenous RD. Tractional detachment can have a secondary break, whereas there is no break in exudative retinal detachment. So talking about the extent of detachment, a regmatogenous RD will extend up till the ora serrata, whereas the tractional detachments are usually localized, whereas an exudative RD mostly are seen inferiorly and usually can extend up till the ora serrata. Talking about the retinal mobility, so regmatogenous RDs have an undulating bullae or folds, whereas tractional detachments are concave, have a taut retina, whereas exudative RDs have smooth elevated bullae, usually without folds. And pigments, which we say as Schaeffer sign, is usually present in regmatogenous RD, not seen in tractional detachments, and usually not seen in exudative RD. Can have retrolental cells if it's associated with inflammatory cause. And the fluid is clear in subretinal space in regmatogenous RD. usually clear in tractional but can be turbid and shows and usually shifts rapidly to dependent positions in cases of exudative detachment. Choroidal mass, as we already discussed, is usually seen in exudative RD and is not seen in rhegmatogenous or tractional detachments. Thank you.
Thank you, Ashish. Very nice presentation, though it was a very large topic, but very concisely and precisely done. Thank you.
Thank you.
Now, I call upon Dr. Alkesh Chaudhary, who is a brilliant VR surgeon. He's going to speak on VR surgery step by step.
Before Dr. Alkesh starts, I still remember, I think some 1.5 decades ago, I had this long question that how do you differentiate between the different 3 types of retinal detachment and describe the steps to manage rhegmatogenous detachment. So I think that's very, this slide his presentation kind of very good, very well delineated the 3 differences between the 3 types of detachment. And I think it's a long time question that keeps coming again and again.
Good morning, dear friends. It is my privilege to present vitreous surgery step by step. So basically, I'll be explaining the vitreous surgery once we are doing how to proceed as a step by step. What are the basic steps? So vitreous vitrectomy is basically the type of surgery to treat vitreous problem in the retina and vitreous during the surgery. The vitreous is removed and replaced with another solution. The vitreous is a gel-like substance that fills the middle of the portion of your eye. So first to anesthesia. Before starting vitreous surgery, different type of anesthesia: topical, local, then retroverbal, periverbal, subtenon, general anesthesia. These are 3-port sclerotomy usually we make of different sizes. So 20 gauge, 23 gauge, 25 gauge and 27 gauge. And on the side you see is a color coding also. The yellow is 23, then 25 bluish, and the pink is 27 gauge. These are the trocar and cannula which are normally used. So now 4-port pars plana vitrectomy is basically when we have to do the bimanual surgery for the thick retinal membrane advanced PR. So in that case you see we use the Chantiel light and we do the bimanual surgery, and this is the irrigation infusion line. Instrumentation, then trocar and cannula. So this is the cannula and this is the trocar, and cutter, and their speed, various speeds starting from 4,000 goes up to 10,000 now. So vitreous cutter. So once you get an exam, different instrumentation they are kept so that you can identify back flush needle, then laser pipe, forceps, scissors. So irrigation cannula, back flush needle, forceps, and all these instruments. Then visualization. So different type of visualization we have: non-contact and the contact. This is the resight by the Zeiss, which is again non-contact. And this is the biome, and these are the irrigating contact lenses which were used earlier but now not used very commonly because assistant used to keep on holding it and half the time sleeping, so we have to wake it out. And these are the contact lenses which is now commonly used, 40 diopter for the membranes to be removed from the retina. So they are self-retaining. You see the flanks on the side, they are self-retaining contact lenses. Then coming to vitrectomy, PVD induction, anterior vitrectomy, mid vitrectomy, posterior vitrectomy, PVD induction, and the vitreous staining with different. So you see this was a case of ERM. So vitreous staining you see with the Kennicott. So we're removing the vitreous after doing anterior and posterior vitrectomy. So You see the retina has been loosened slowly. It was a case of BMT, so we have to be very careful not pull the vitreous. Slowly now we have detached from the this total detachment of the end, removing whole of it and settling this, removing vitreometer interaction. Now this is another case of like staining of the membrane with Canacort, Retiblue. Identify the cleavage area, removal by forceps. Now use of forceps, how they are used. Thick membranes by manual dissection. This is a case of ERM. So you see this stained with the Retiblue dye under first with the Canacort. So make sure we remove whole of the vitreous. Once vitreous is removed, so you see the vitreous stands and removing whole of the vitreous. Now fluid air exchange we do, and under the air we stain this membranes, because in the fluid if you stain this whole dye will get mixed up with the fluid, so it will difficult. Now use of forceps, you see now using this epiretinal membrane from the retina. So this how nicely we remove whole of the membrane from the retina with the help of the forceps. Coming to next, how the fluid air exchange, another role. This was a case of retinal detachment. You see anterior, posterior vitrectomy being done, and we make sure we cause the retinal PVD, also complete PVD. And this you can see the big hole, and this is the base dissection. Basically after indentation, how we do the vitreous base. So then the mode of the vitrectomy changes into shear mode, where the cutting rate is very high but suction is low, so that we don't cause damage to the retina and don't cause dialysis at this area. Because if we pull the retina, pull the thick vitreous, now we are trying to stain the retina with Canacort and you see whole of the vitreous is removed. There is a no further. And doing the diathermy retinotomy for the fluid drainage, you see the air is coming and the fluid is being drained with the back flush needle. Now there is a roll of now back flush needle from the retina, and retina you see is settling well. Now you see finally the laser, endo laser is being used now along the retinotomy and along the hole. Now this is the silicone oil we are injecting, and finally we titrating the pressure also. So removing all the cannulas, you see how the nicely it is settled, and we don't need any sutures. So these seals are closed. This was a 25 gauge again. Now you see the endo laser probe, how it is a straight probe and curved probe. With the help of a curved probe we can go to the periphery. So this is along the retinal hole retinotomy. If there is a branch, other cases like diabetic retinopathy, any NV or ischemic areas, we have to do laser. Now vitreous cavity is a filling. This is a 27 gauge. See the pink hole, just thick vitreous with the TRD, so being removed with the 27 vitrectomy. So finally the vitreous cavity is being filled with the BSS gas, C3F8, SF6 or silicone oil. Silicone oil showed in the previous video. Now this is a phaco in vitreous cavity. This was a case of nucleus drop. Basically you see when it came to me, so we always tell whenever you do the phaco, don't leave the wounds unscured. So this was a leaking wound. We are just closing that wound nicely, so that now going with the 25 gauge on the two side and when making 20 gauge with the MVR blade, so that we can do the vitrectomy and finally phaco fragment. This is a complete nucleus with the phaco fragmentation, and the light pipe I am using to break this nucleus. So this is happening phaco in the vitreous cavity. So nucleus being broken into small pieces and finally being removed with the phaco fragmentation. So in this case PVD is must before doing phaco, because this fragmentome is going to, if there is a vitreous, it will suck the vitreous also and may cause retinal detachment and cause other problems. Now see, putting finally the cleaning the area behind also the cortex, putting finally the lens in the sulcus.
You see, I have put the lens, but the trailing loop I have left behind so that this doesn't fall. Now this place in the sulcus, and finally this is also placed in the sulcus, nicely placed tap. You see now this vitrectomy port is being sutured with the 70 Vicryl. So other ports need not don't need suturing 25K, they are self-sealing. So the closing of the port is self-sealing eye with the help of a suture. If you do 23 gauge vitrectomy, sometimes you need a single suture. So closing is a cannula removal, simply self-sealing. 23 gauge you need one suture. So either 20 gauge you need 70 Vicryl to put mattress suture. Thank you so much.
Thank you, Dr. Alkesh, for that really aggressive talk on VR surgery step by step. I think one of the key factors that Dr. Alkesh covered was, and which is usually asked in exams, is instrumentation in VR surgery. I think instrumentation is one, and secondly, vitreous substitutes is also something that is really asked in exams. Thirdly, I think if any one of you, I think, reaches the Viva stage where they start talking about VR surgery, I think these complicated surgeries of vitreous procedures is something that he's very described very well. So thank you, Dr. Alkesh. Any questions from anybody, because we're not having any interaction at all. I think this is not something where it's a meeting where we need to interact, right? So any questions from anybody? I think for any of the talks rather. No doubts. Then I think I'd like to congratulate all the speakers. I think we've done a very good job.
So the first thing for a VR surgery, when you introduce the cannula, you have to see that it's in the vitreous
Within the cannula.
So the most important part of a vitreous surgery is that you see that the cannula is in the vitreous cavity. Otherwise, you're going to end up with a hugely more difficult vitreoretinal surgery than you
Choroidal detachment. If it is not in the vitreous
so
cavity,
it's become kind of a part of a habit, the reflex.
Since we're talking about the beginning vitreoretinal surgeon, so for them the first thing is check that out. And in fact, not only check that out, but if during the course of surgery you feel somebody pulled at that cannula, recheck it again, because you could find that you've suddenly shifted it into the subretinal space, and you're going to get a bullous detachment after that. So this is the most important step for you. The second thing to know is that the vitreous base, the vitreous fibrils are into the substance. You cannot separate out the vitreous base, the vitreous from the retina at the vitreous base. So at the vitreous base, what you're trying to do is shave it. You're only trying to remove as much as possible, but you can't possibly separate it out completely. So you don't pull beyond that point. This is the other important thing. So you're doing a PVD, but the PVD, you have to make sure you don't pull too much at the vitreous base. That is where the retina is thinnest. So
right.
And it's thickest at the
What is one sign when, I think as Sir said, so when you're inducing a PVD, I think if what is one's first is that how do you check the cannula? So anybody wants to enlighten us how to check the cannula? Okay, so usually the cannula tip is silver color, so you're not supposed to see a brown element in front of it, because the brown element would be a choroid, so that means it is still subchoroidal. Or if you see a white element in front of it, that means it is still subretinal, right? So that means that you have gone more posterior. And the positioning basically in a phakic, you go at 3 mm usually, and in a pseudophakic at 3.5 mm, and in a phakic patient at 4 mm. I think the most idealistic way obviously is to do an indirect and check, but yes, otherwise you can depress the cannula a bit and just turn the eye and you can check the cannula.
And
later too.
And illuminator is, and secondly, especially in the phakic eye, you have to be careful. You don't damage the lens.
Yeah, so in that
While
an indirect could be a very good way.
So the best way is a light pipe from the other side and mild indentation along the cannula. You will be able to see the cannula very well.
And as Sir was saying about PVD induction, so when you're inducing a PVD and if you see a trickle of heme from somewhere, that means that you've induced a brake somewhere while, you know, increasing the PVD towards the vitreous space. So there is a way, I mean, when you go, you need to stop at a level, and then as Dr. Alkesh showed, I think, you know, shave the base very well to not have any peripheral breaks later on. So thank you. So moving on to the next
Thank you
talk.
so much.
I'd like to invite Dr. Tinku Bali, who would be now taking forward Ashish's talk and explaining retinal detachment management. Thank you. Dr. Tinku Bali is a very proficient VR surgeon practicing at Gangaram Hospital.
Pointer. Hello, good morning everyone. So my talk is going to be concentrated on the rhegmatogenous retinal detachment, and I'll not be showing you surgical videos or giving you surgical tips. I'll just be helping you in how we make the decision making process of what modality to choose when we encounter a rhegmatogenous retinal detachment. So the main principles of a retinal reattachment are to identify and close. First is to identify, and then is to close all the retinal breaks and to relieve the vitreoretinal traction. You may or may not drain the subretinal fluid. It is not important. As long as you have done these things, your retina is going to attach. And if you've accomplished this without any complications, the development of new breaks or the development of PVR, your procedure will be successful. Now, in the identification of the breaks, it's important when you're examining the patient to see the size, the number, and the location of the breaks, because that will help you decide what modality you want to do for this patient. Now, most of the breaks, 60% of the breaks would be in the supratemporal quadrant. So look at this quadrant very carefully, and most often you'll find breaks here. The other quadrants, 15% here, around 15% here, and the least number of breaks would be in the inferonasal quadrant. So this is a tip for you. And in more than 50%, in around 50% of the cases, there would be more than one breaks. There would be patients having 5, 6, even 10, 12 breaks. So don't just stop when you see one break and think that, oh, this is the break we've identified. More important, you have to identify the break that is actually causing the detachment. And as Dr. Markan showed you, the Linkoff's rule. So I'll just again recapitulate the Linkoff's rule. So it's very simple actually. Whichever side your retinal detachment is higher, that is the side your break is going to be. So see this inferior retinal detachment, this side is higher, so your break is on this side. This is a superior retinal detachment, but you see both the limbs here, this side is higher, so your break would be somewhere on this side. In a total retinal detachment, which is bullous, or a subtotal where you have just this little area attached, your break will always be in the superior quadrant, somewhere between 11 to 1 o'clock. Now again, this inferior detachment, you see this side is more than this side, so the break will again be on this side. Now this is an inferior bullous retinal detachment. So in an inferior bullous detachment, many times you will not find any break in this area. And that is the time in the inferior bullous detachment, there is a gutter and the break is generally here on the upper side. So in an inferior bullous detachment, do have a look at the superior quadrant and the fluid will be tracking down from there. Now these are modified Linkoff's rule. The Linkoff initially had given just 4 rules, and when you talk about these, you have to say these are modified Linkoff rules. Recently, a lot of authors have added to these rules, and there are 4 more rules that have come, but I think that is too advanced for you all. So these are modified Linkoff's rule, which you should be aware of. Now just to throw some light on the progression of a retinal detachment. So whenever a break forms, the fluid tracks into this break, goes all the way to the ora, and then you see this is how the retinal detachment will progress. 1, 2, 3, 4. It will go all the way around the disc and then go to the other side. So this is how the retinal detachment progresses. So if there's an inferior break, it will be here, then here, then here, then it will gradually reach the disc and then start going to the other side. Now, breaks in the superior quadrant spread very rapidly, and breaks in the inferior quadrant have a slow progression. So many times you'll see that patients have these kind of demarcation lines, which are also called high water marks. And sometimes there may be multiple such high water marks, and inferior detachments progress very slowly. It's only when they reach the macula. Sometimes they may stay there for years together. and only when they reach the macula that the patient starts having visual symptoms and comes to you. When we examine the patient, again, it's important to see whether the macula is off or on. You can also do an OCT if there's doubt, where you'll actually see whether the macula, the fovea is off or not. And this helps us again in deciding the urgency of our surgery. You also should identify other associated features like lattice, vitreous hemorrhage, proliferative vitreoretinopathy, and choroidal detachment. Now, again, a lot of residents make a mistake when in PVR. PVR is proliferative vitreoretinopathy. That is the formation of membranes on or under the retina. And this term is not used in diabetic retinopathy. A lot of residents use this term in diabetic retinopathy. That is proliferative retinopathy. This is proliferative vitreoretinopathy, to be used only in cases of retinal detachment. Now, ultimate post-operative recovery depends on whether the macula is involved or not. So if the macula is attached, generally we like to do a very prompt surgery, sometimes on the day itself. But recent studies have shown that even within 3 days, the visual outcomes are the same. In case the macula is detached, then you can post the patient whenever you have your next operation day. In case you're delaying the surgery, then a lot of people tell the patient to take bed rest. Bilateral patching was advised in previous years, though it's a little cumbersome, to eliminate the internal fluid currents which cause the retinal detachment. Now, the main principles of treating a retinal detachment is to either bring the eye wall towards the break or the traction, which is done by using a scleral buckle, or to push the break towards the eyeball, either using gas or oil, which is done when we do a vitrectomy, and then to seal the break with retinopexy. And this retinopexy can be done either with laser or with cryo. So the 3 commonly used surgical techniques are pneumatic retinopexy, scleral buckling, and vitrectomy. Most often we do a vitrectomy. It started off with scleral buckling in the previous eras, but now the newer surgeons have moved on to vitrectomy. And pneumatic retinopexy is again finding favor with a lot of surgeons. It lost flavor in the preceding years, but it's again come back and becoming very popular, especially in USA, not so much in Europe. And even in India now we are doing a lot of pneumatics. So I'll just elaborate about pneumatic retinopexy. In this, an expensile gas. This is 100% concentration. So this is an expensile concentration. We inject this gas, which pushes the break, which pushes the retina towards the RPE, and then we can either do a cryo or a laser to the break, and appropriate head positioning of the patient is extremely important. So this is the fluid that is going through the break. This is how we inject the gas bubble. This gas bubble is expensile because it's pure gas. It will expand. It will tamponade this break. So the 2 terms that you need to know are surface tension and buoyancy. So the surface tension of this gas will close the bubble, and since it is buoyant, it will push the retina against the retinal pigment epithelium. It will expand, and gradually this break will seal and the gas will gradually get absorbed. So how do we do this? In this procedure, when we can use either of the 2 gases, SF6 or C3F8. When we use SF6, we use a higher volume, a lower volume for this. SF6 is generally used when the break is small, and C3F8 when it is larger. So you go through the pars plana with a 30 gauge needle, you inject a small bubble, you withdraw the needle and go little back, and in one push you inject a gas bubble. You don't want small bubbles, otherwise they could go through the break. So a large bubble has to be injected, and then you come out and ask the patient to position his head so that the break goes against the break, so that the gas goes against the break. Now this chart is very, very important. So this shows the expansion of the gases. SF6, it reaches its largest size in 36 hours, it doubles in size. C3F8, it quadruples in size in 3 days, it stays in the eye for much longer. Air is generally not used in pneumatic. So this chart is extremely important for you. A lot of questions are asked on this. So for pneumatic retinopexy, case selection is very important. So a single retinal break or a cluster of breaks within 1 clock hour. They should not be scattered here and there. The breaks should be in the superior 8 clock hours. There should be no PVR. There should be no inferior lattice degeneration, because when you inject the gas, it can cause fresh breaks if there are inferior lesions, and the patient should be able to maintain the position. It does have a success rate of 80%, but then we can always do other procedures if pneumatic retinopexy fails. Complications could be subretinal gas, new breaks, macular hole, and extension into the macula. Now, scleral buckling, I won't go into the details of the procedure, but just to tell you which are the cases that we would like to do scleral buckling in. So, a retinal detachment where the breaks are indentable. So, when you do an indentation and your indenter can reach the break, that means your buckle will also be able to reach the break. The break should not be very posterior. So, for anterior breaks where your indenter can reach up to, those are the cases where you can do a scleral buckling. There should be minimal PVR, there should be no PVR or very mild PVR up to C1, that is fixed fold in one quadrant maybe. No vitreous hemorrhage or choroidal detachment, and retinal detachment in young patients. These are cases where we like to do a scleral buckling, because with vitrectomy these patients you're going to induce cataract. So in young patients we prefer doing a scleral buckle. The success rate of this procedure is 90 to 95%. It has a very good success rate. The risk of PVR formation is very minimal, and endophthalmitis risk is very low. Progression of cataract is very less, and no positioning. I'll just take 2 minutes more. Okay. So, vitrectomy we do when the break is very large, because such breaks, if we do scleral buckling, will cause fish mouthing, and sometimes you may not be able to cover the entire break with the buckle. The break is very posterior. If the PVR is too much, more than C1, that is the retina has a lot of fixed folds. So those are the cases where you cannot do a buckle. Giant retinal tears, retinal detachments where there's vitreous hemorrhage, because you'll not be able to see inside when you're doing buckling. When there's choroidal detachments, coloboma. So these are the cases where we like to do a vitrectomy. And after a vitrectomy, as Dr. Alkesh was showing you, we put in a tampon adding agent which will which will close the break. The tampon adding agent is a very temporary agent to close the break while your retinopexy seal. The retinopexy that you've done, the laser that you've done inside, takes some time to close the hole. So in the meantime, these tampon adding agents will seal the hole. And in this we use a non-expensile concentration after vitrectomy, not an expensile. So this we use diluted gas, SF6 14% and C3F8 20%. So we can either use gas or oil or heavy silicone oil, which is Denseron, and this is generally preferred in inferior retinal detachments. So when do we use gas and when do we use oil? So gas generally when there is no PVR, there is no membranes or traction on the retina, we've been able to achieve a very good relief of traction. The breaks are superior, the breaks are few, the patient can position. The patient has the other eye which is seeing, because once you put gas, the patient doesn't have any vision till the time the gas is in the eye. So if the patient is only eyed, then you will not use gas. And when you're doing a primary surgery. Oil, when you think you need a longer tamponade, when the retina has a lot of PVR, the retina is very stiff, the breaks are inferior, there are multiple breaks, the patient cannot position, it's a one-eyed patient, or you're doing a revision surgery, those are the times you use an oil. So vitrectomy eliminates all the media opacities. You can actually go and see the break, localize it and seal it completely. The disadvantages are, of course, cataract formation in phakic patients, higher cost of surgery, and if your surgery fails, it causes PVR, and in case oil is used, then you need another surgery to remove the oil. Now, a failed retinal reattachment is only because of two things: either you have missed a break, or either there was an initial attachment followed by a redetachment due to PVR, that is proliferative vitreoretinopathy. So then we have to take care of these two things. So in conclusion, pneumatic retinopexy is a simple procedure, but case selection is extremely important. Like I said, superior breaks only limited to one quadrant. Scleral buckling is a very good modality for young phakic patients. And vitrectomy can be done for almost any RDs. So most retinal detachments can be treated with one of these techniques, and there is no right way. The choice of the procedure is influenced by a surgeon's preference, choice, and training. And thank you. Yeah.
Thank you, Dr. Tinku. It is really nice for all the postgraduates. They can write their answers very well with your talk. Thank you. Any questions?
And one more indication of scleral buckling in the periphery when the vitrectomy machines are not available.
Yes. Yeah, it's a simple and low-cost procedure.
They can do that.
Yeah.
So going forwards, I would like to invite Dr. Dinesh Talwar. He's a proficient, prolific vitreoretina surgeon with Center for Sight, and he has, I think he has taught many of the vitreoretina surgeons, and including me. And it'll be great to hear him for diabetic vitrectomy, practical tips.
To the probably cutting edge of whatever we do in vitreoretinal surgery. However, for those of you who end up with a gold medal, it may be worth having some idea about what
They can prepare for future in advance.
and those of you who have an interest in retina or who are on the fence, maybe some of the things which we talk about will.
Sir, actually, there is a long question in I think usually in DNB exams that they ask is what are the indications of intervening in a PDR case. So I
Yes,
think your
but
talk would
unfortunately,
be
the talk is on the surgical
yes,
procedure
for
rather
the
than
surgical part itself. So what are the indications and where you will intervene in a
So-
surgically in a diabetic case?
So anyway, so let's start from a diabetic vitrectomy is like planning for a major surgical strike. You know, all the other surgical strikes, Air Force, वगैरह, but this is also a surgical strike. And in any surgical strike, you must have reconnaissance, which is first gather the intelligence, know where whatever you have around. What he's talking about, you should know whether it's the time to go in. Then you do when you go inside, you do your initial foray, look around, how difficult is the case. Plan your general strategy, and then you must have a nimbleness in execution. You must be able to change when you find something is not going the way you thought it would. The first strike starts with an anti-VEGF in most of these cases. We've seen that giving an anti-VEGF around 48 hours before the surgery decreases the risk of bleeding during the surgery. Also makes it possibly, I mean, this is just a feeling that maybe it decreases the strength of adhesions of these stocks, makes them a little easier to remove. But this is not something that you can say is documented. So we can't say that really this happens. So as I said, when you come to reconnaissance, what are you looking at? You're looking for openings within the area where you're doing surgery. Space between the membranes and the retina in all 360 degrees of the retina. You want to see the intensity of the adhesion of the retina between the retina and the membranes, and you want to check up which are the potential stalks. Unlike a rhegmatogenous detachment, here you have vascular stalks from which if you pull too much, you could have a bleed or you could get a break. Normally for these initial forays, we've been using a 25 gauge MVR to pick the membrane off the retinal surface and create a wedge for insertion of a cutter. You can use an Alcon blunt spatula to create the separation between the membrane and the underlying retina. It's an atraumatic way of doing it. And then you use the blunt edge of the cutter to lift the membranes off the retinal surface safely. The important thing is that if you see bleeding occurring in a particular area under the retina, under the membrane, you stop, because otherwise you'll end up with a large hemorrhage over there. You move radially from the periphery to the disc from multiple directions, looking for areas where the adhesions are least sticky. But you can also go inside, do an inside-out approach, starting just adjacent to the disc to assess the severity of this adhesion of the membrane to the underlying retina. The most important thing is avoid breaks. You don't want breaks in this. It will complicate your surgery too much. We use a scissors as a shearing instrument. You see, both edges of a scissor are actually blunt. It's only when they meet each other they cut. So if you use one edge of the scissors as a shearing instrument, you can separate out the membrane from the underlying retina. And segment in case the stalk is big or very adherent. Just chip away, have patience. The most important thing in vitreoretinal surgeries, and especially diabetic vitrectomies, is patience of the surgeon. And finally, when you've done all this, you need to do peripheral clearance of the cortical vitreous up to the vitreous base and anteriorly. and remove all those focal areas of adherence in the mid peripheral retina, because otherwise long-term success will not happen. You will immediately, the retina will settle, but later on you'll have a problem. Just to show you how, now here you have a stalk, we're removing this stalk, cutting it, shortening it, now you're separating out with the MVR. Now you see there is an attachment there, and this attachment is just behind the, it goes downwards. If I had pulled, it will just tear. Now even this stalk at the disc, you'll see sometimes these stalks are not just straight up, they are whirled. So you'll see over here, I'm gently going to separate it out, because if you are able to remove it from its root, it doesn't bleed. Whereas if you just tear it off, the vessels which are there will keep bleeding. So it's important to, I mean, it's a small thing, but makes a lot of difference to your surgery. You want to remove the stalk from its root. You don't want to tear the stalk. And this is what we are doing. We are seeing it, this was not the right position. Pulled it downwards, separated out, still not out. And you see finally, when we moved it towards the nasal side, it just gently came out. You know, it just comes out easily. And then the entire membrane now separates out. So it's important to find the plane of separation, identify the stalks and segment around them, avoid creating bleeding points, avoid the spread of bleeding. You don't want bleeding to spread, because that forms another membrane for you, and diathermize only after removal of traction. Just to show you what happens once you've diathermized. You see over here, there's this small area there where it was diathermized after removing the traction, but when we went in to remove this blood, because still some bleeding was happening, and look what happened. It's very prone to breaks. So first of all, use gentle diathermy, the most gentle that you can to close the bleeding, and then also only after you've removed all the traction. The other important thing, now sometimes you could have a break. Now you have a break over here, and now you have to remove this traction. So this has to be done bimanually. You move towards the break, never move away from the break. You'll see I had an option to move away from the break, which was easier, but I'm going towards the break, removing this traction, and this is bimanual separation, because if you go away, it will tear further. You have to go towards the break in each of these cases. Yeah. Now, sometimes you can have a very tenacious membrane. It looks very simple. See, small membrane, यहाँ से खींच दूंगा, macula भी खट जाएगा. Okay, so now you see over here, we created a separation, found still very tenacious, not going easily, so decided to segment it rather than pull it too much. So created the separation, and then after creating the separation, we're using a vertical scissors. So use all your instruments. You have vertical scissors, curved scissors. Here we're using a vertical scissors to make the separation, and we found still no, there's another layer there. So sometimes there can be multiple layers of membranes in a diabetic. So now separating this out, and you will realize how intense, how thick this membrane is, and goes all the way. See, it went all the way to the periphery, and it goes downwards all the way, right? Supposing it had been pulled, this entire retina would have been pulled out. So this is the important thing. This is just to show you the shearing technique for using the scissors. Now you see it's bimanual. I'm holding with the forceps and using the scissors just to separate out the plane. I'm not cutting, I'm just separating it out. And once I've separated it out, then I will use, once I've got the view, then I will cut. Same thing here. I'm using the scissors as a shearing instrument, separating out the membrane from the retinal surface, and then only cutting. And once I've done that, I cut it. This is another, sorry. Now, this is another thing which sometimes a vitreous hemorrhage looks very simple, but this is where an ultrasound was important. It showed there was a detachment also. So though this vitreous was looking very mobile, but there's a detachment under this. If you use too much suction, you'll get the vitreous and the retina together, because they are attached finely in the periphery. So gently you keep on removing the vitreous, in all the various parts of the periphery till you get a hole in the vitreous, and you can find the separation. So this is what we did. Now you see we've got this separation. Then we completed the PVD. I didn't want to pull too much. You pull in a detached retina, you'll only make it worse. Okay. Now this sums up everything that we've done. Okay. This is a case which is a bad case with a combined traction rhegmatogenous detachment, very sticky membrane. Now you look here, we tried in the supranasal area, separated out, got some separation, went to the disc, got a bleed, left it, picked up another site, inferonasally. Now we're separating out the membrane over here, and you see how sticky it is. We managed to separate it at the disc. Each time you keep removing the blood which comes, don't let that collect. Again, you've got this bleeding over here. And you see, again, you have to persist, separate out the membrane, visualize, go further. Tried to go from the periphery, realize it's not going to come from there. And finally decided this needs bimanual surgery. So using the bimanual, now holding with forceps, cutting with the scissors all the way to the periphery till the membrane separates out. And you can see that it's attached everywhere, the multiple points of attachment. You have to remove all of them. And you saw this hemorrhage. I actually waited for some time, and this hemorrhage then took an hour to remove. So it's just the video is small, but it took an hour to remove this hemorrhage because it became a thick tenacious membrane. And now we use PFCL to support and realize there's still some membranes there. So removing these membranes, using the shearing process as I showed you. Sorry. Separate it out, then put PFCL to see that all the traction's gone. Went to the mid-peripheral retina and the periphery, cleared it, and then you put silicone oil. So this is just to show you that you can do surgery even in very, very complex cases, and you can do that successfully. But these vitrectomies are deceptive. Sometimes they look simple and they turn out, like I showed you, a tenacious membrane looks very simple to remove, sometimes can be very difficult. So don't underestimate the difficulty of the surgery, which is why now when you talk of indications, I would not intervene in patients with good vision even if the traction detachment looks simple, because sometimes two things. One, diabetic optic nerve is very friable anyway. Okay, in fact, it's well known that diabetic vitrectomies if you see the DRVS, it reports 25% of eyes lost PL negative vision despite surgery occurred. Even today, I think 10 to 12% of eyes you can lose because of this. Even in diabetic macular edema, if you do surgery, what looks like a simple surgery, more than 25% of patients will actually lose vision rather than gain. Only 30% will gain vision. So I'm just showing you the lot of membranes which are there, which you can't anticipate sometimes when you do the surgery. So it's very important to make sure you only go in when it's indicated. I would do surgery only when the vision goes down below 618 or 624, not in patients with 6'9", 6'12", because there is a threatening macula. No. I would still wait for it to go down. So this is the important thing. The important thing is when you do this surgery, have patience, don't be in a hurry, and success will follow. I am dedicating this particular talk to my guru, Professor H.K. Tiwari, who was the chief of RP Center at one point of time. He's no longer there, but he will continue to live in our hearts, and it is his prodding which actually forced me to start making videos of my surgical work. Otherwise, I had a fetish about not making videos. Thank you very much.
Thank you, Dr. Dinesh, for your excellent presentation and making difficult things simple. And I also remember when I was in Shankarnetralaya, my teacher used to say, if you don't have a patience, don't go into vitreoretina. Don't go for retina surgery. So patience is must for these difficult surgeries to do well. Thank you, Dr. Dinesh. Any question with the Dr. Dinesh? Now we invite Dr. Sarita Veri, who is a very great vitreoretinal surgeon in the department of retina in Lady Harding. Dr. Sarita
Thank you, Dr.
will
Alkesh.
be sharing her vast experience with anti-VGF and update.
Good morning all. At the outset, I'd like to thank DOS and Chief RP Center for giving me this opportunity to speak on this topic. We are again back to our PG level. And this is a very important topic because either a short note or a full question or a very long question definitely will come to you. So, anti-VEGF has not been covered in all these talks. So, my topic is anti-VEGF update, but I will quickly brush through the basics of anti-VEGF as well. So I will be covering up my topics like this and saying that the angiogenesis, the angiogenesis term came much earlier, as you can see here, and the concept of anti-angiogenesis also came back in 1971, while the VEGF name was started in 1989, and clinically we started with anti-VEGFs in the ophthalmic problems in 2004. So VEGF is produced in the retina by nearly all the cells, and what does it do? It affects also nearly all the tissues, but affects the endothelial cell wall. So this is the endothelial cell wall where you have these receptors, and this VEGF comes to these receptors and produces a cascade which is responsible for the normal growth of the blood vessels and is also having a neuroprotective role. So these are the various VEGFs which have been found out, and the VEGF-A and placental growth factor are the ones which are important for the ophthalmic point of view. So they cause this angiogenesis, vasodilatation, inflammation, chemotactic, and also increase in permeability. So what causes the increase of VEGF is the tissue hypoxia, which increases this abnormal VEGF-A, abnormally high VEGF-A, which will then bind to the same receptor which the VEGF was binding to, and causes this cascade, which was for survival, but now here it can cause abnormal vascular permeability, causing edema, exudation, hard exudates, and angiogenesis, that is new vessel formation, so which is pathological. So then came how to counteract this VEGF. So to counteract this VEGF, which is now producing a havoc, so these anti-VEGF therapy agents came up. The first one was an aptamer, which is not an antibody, it's a nucleic acid small, which I will be discussing a little later, which VEGF, it is only for an isomer of 165 VEGF-A. The most important one which came up and was widely used, though off-label, is the full antibody. You can see from our microbiology, this is FC fragment and this is the FAB fragments. FAB is the one which is active and gets attached to the VEGF, which is the antigen here, and this monoclonal antibody binds to all the VEGF-A isoforms. So then they thought not to have this area and have only this FAB fragment, which is the ranibizumab, and so this would be also binding to all the VEGF-A isoforms with higher affinity than the bevacizumab. Then came aflibercept, which along with this monoclonal antibody, there were some protein fusion proteins which would then, and this has another important thing, that it binds to both the sides of the antigen, so it forms a VEGF trap. So this is again showing you how this aptamer, which was pegatinib, would challenge this VEGF 165 to get connected to this VEGF-R. Same bevacizumab will take away this VEGF-A and not allow them to come to the receptors, and hence this pathway. Ranibizumab, this is a fragment of FAB, and the aflibercept We'll be talking again about this. So this is again giving a picture view of these greens are the VEGFs, and this is an aptamer which is getting attached to this VEGF so that it chelates it and does not come to this receptor. The ranibizumab, the bevacizumab, and aflibercept, it is trapping it and not allowing it to come to these receptors on the cell wall of the endothelial cell, and hence causing all that angiogenesis, inflammation, and permeability. There was a lot of interest on this drug called brolucizumab because of the extended dosing schedule which was thought it could give, and it's a smaller molecular weight and has a greater drug penetration, but it had little side effects of intraocular inflammation and retinal vascular occlusion, which was thought because of the increased dosing. So FDA has approved with after the first 3 doses, it has to be increased to 8 weekly or 12 weekly dosing. Another drug, faricimab, is also now in the market by the name of Vabysmo, and it has 2 antibody targets like angiopoietin 2 and VEGF. It's a larger molecule, and it is now available in our market, Indian market as well. Just the timeline, this has already been covered to just show that in 2019 the brolucizumab came in, and 2022 the faricimab came in. All these were earlier. So the names of it has gone up. I don't know how it has gone up. So this is ranibizumab. The first one is the ranibizumab, which is a FAB fragment, and you can see that this is a FAB fragment at 48 kilodaltons. This is bevacizumab, a large molecule, 149, and this is aflibercept, which is also known as VEGF trap. It's a large molecule with proteins, and 115. Single chain, it's a fragment. Brolucizumab is a single chain antibody fragment, smallest of the anti-VEGF. It could be MCQ as well. A smallest of the anti-VEGF, 26 daltons, and this is the faricimab, which is both VEGF-A and angiotensin 2 inhibitors. So these are the various trials which have been covered earlier also on Friday retina lectures. So this will give you a fair idea for various pathologies, what are the various anti-VEGF which can be, and the various important trials. You can take this slide later on, and hence after those trials there was a FDA approval for these drugs for these various diseases where it is used. Like ranibizumab has it for all, brolucizumab and faricimab has for wet AMD and DME. Bevacizumab is also for all, but still it is off-label. It is used for colon cancers. So the treatment regime is important. After giving the first 3 monthly doses, it could be treat and extend or treat and PRN. Both of them have advantages and disadvantages, and it is the surgeon's choice to go on. Other uses of anti-VEGFs are wherever we do not want vascularization, like in pterygium, chemical burns, post-keratoplasty, herpetic, and Stevens-Johnson syndrome. The side effects most important are endophthalmitis and detachments. Systemic, like thromboembolic phenomena and myocardial infarction, and you must take the history of cardiovascular events, stroke, CVA, and in case there is a TRD in diabetic vitrectomy, we are giving it prior to the vitrectomy, but it should be operated within a week or 10 days, because otherwise the TRD will increase. The vascular components becomes fibrous and the TRD increases. So we be sure that it can be operated earlier, and even if there is infection, we do not give anti-VEGFs. So it is done in aseptic conditions. Biosimilars, a word, they are similar to innovative biologics, same pharmacokinetics, but a little different. And biosimilars approved in India are the Razumab, no financial interest. Importance is because of affordability and accessibility. A word about ESFLE, which is a biosimilar of aflibercept, and is in Europe it has got its approval and it is now being used. So the latest innovations guides are there should be a longer duration of action. The target should be more physiological, not only VEGF but others also, which will also could produce vasculogenesis and to reduce systemic and ocular side effects. So other VEGF blockers, other VEGF-A blockers, like because they also have platelet growth factor inhibitions. Then sustained delivery systems, will talk about nanoparticle delivery and VEGF-A, along with VEGF-A, VEGF-C, and VEGF-T, and gene therapy. So Concerbapt is used only in China. It's same as aflibercept. Azipipam is in the trials. It is in the phase 3 trials and has higher affinity and longer vitreous half-life. Fovista is platelet-derived growth factor inhibitor, is also in the clinical trials. Trap molecules, as we see that aflibercept and ranibizumab, they inhibit these, but they increase the VEGF-C and D. So therefore, we need something to down-regulate VEGF-C and D also. So they are also in the pipeline, which can be used as a monotherapy or a combination with ranibizumab and other VEGFs. So gene therapy is very interesting. The gene that codes anti-VEGF FAB fragment of the monoclonal antibody protein is incorporated into the vector virus, injected subretinally, and these will then produce the anti-VEGF which will be required for the cure of wet AMD. So it's a single time injection. So these are also early trials and have good results. Similarly, aflibercept coding is also being done so that this can be used. Now, nanoparticle delivery is very interesting with PLG and nanoparticles. All these drugs which we have talked can be converted into this nanoparticles and then delivered, which could be sustained release, increase half-life, and offset the drawbacks and side effects. The best would be the topical anti-VEGF agents, which can be added. These same drugs can be added to the cell-penetrating peptides. They can be given topically, and these cell-penetrating CPP will carry this drug into the posterior segment. So how interesting it would be, no injections. And the port delivery system is also on the stage 3 trials, and it is permanent reusable. So this is a port delivery. It has a septum from where you can inject whenever this gets filled, needs a refill. And this has a release control element of titanium diaphragm. So you can refill it and you don't have to enter the eye with the injection. So these are also in the phase 3 trials, and we'll be able to get them. So take home message would be that anti-VEGFs have revolutionized the management of retinal diseases. One should be prudent in the choice of anti-VEGF. Patients should be counseled that they have to come for multiple injections. Sometimes they think one injection, it is all done, they're good. So they have to be told there are going to be multiple injections, how many you can decide. Complications and side effects of anti-VEGFs, definitely if they've had a stroke in the last 3 months, they have to be told that this could be a complication, and better to avoid anti-VEGF, give something else like steroids. Newer innovations in the form of delivery systems and longer acting drugs would further improve the results of anti-VEGFs. Thank you. Thank you.
Thank you so much, Professor Dr. Ved. You have presented so well, precisely and in detail about anti-VEGF. Thank you so much. Any questions from Madam? So now, before we conclude the session, I will request Chairperson Brigadier Mishra and Dr. Sarita Berry to give certificate to the faculty, please. And General Parihar is also there. I would like him to join, please. So Dr. Sandhya Makhicha.
Dr. Sanjay Mishra. Dr. Ashish Markan. Dr. Dinesh Talwar. Dr. Tinku Bali. Dr. Alkesh Chaudhary.
Now we hand over session to the next. Somebody has left his glasses.
हाँ मैं नहीं ज़्यादा स्लाइड शो ही डाल दो, स्लाइड शो डाल दो, यूज स्लाइड शो, yeah that's easier.
Shall we start?
Is there a break?
I think so. 5 minutes we can wait.
Okay.
Probably they are having.
They are having breakfast outside. No, no, no.
Good morning, ladies and gentlemen. It's my proud privilege to chair this session and invite none other than the best among the lot and best outside also, Professor Vanati in cornea. And her topic is endothelial corneal dystrophies. Those who are missing they are missing a lot, I am very sure.
Thank you, sir, for your kind introduction, and thank you to the executive team of DOS for making me part of this nice teaching program. Have no financial interest in what I am going to mention during the course of the next 10 minutes. I have largely tailored it to the requirements of postgraduates. I've not made it like a conference talk because that doesn't really help postgraduates. I've really put in the points which you need to be knowing when you're sitting for an exam, and which you need to be knowing in terms of current concepts of how to approach a corneal endothelial dystrophy. So that's how it's going to be. You might find it very basic, but that's intentionally kept basic so that it has a very good, the teaching quotient is very high on this, and would like to acknowledge Dr. Neha, my senior resident, for all the academic inputs which she had given for this presentation here. I would skip all these things on, I think, what a dystrophy is and what's the difference between a dystrophy and a degeneration. I think most of you are now probably exam-going postgraduates or senior postgraduates here. The junior ones, these I'm just going to touch upon these so that you will go back and revise this. You will need to know what the definition of a dystrophy is. You will also need to know what are the differentiating features between a dystrophy and a degeneration. These are the common questions which are either asked in your vivas or when you are writing your answers in terms of short notes or long essays here. What you need to know in terms of current concepts. How have the current concepts changed the way we look at endothelial dystrophy? We have what is known as the international classification, 3D, the IC3D classification here, which is an updated version in 2015. It's freely available online for all of you to go and read as well. And for those of you who are not familiar with that, I would recommend that you do pull out that paper and read out, because it's a very nice comprehensive read which is not possible to be covered in this 10 minutes here. And this again is going to be only curtailed to the endothelial dystrophy part of it. So what has changed, or what IC3D has changed in the way we look at dystrophies in the cornea here, is that it has introduced what are known as categories based on the identification of genes and chromosomes which have been defined here. And the first point is it has taken out all dystrophies earlier which were linked to the membrane layer of the cornea. So the Bowman's and the Descemet's membrane related dystrophies have now been removed in terms of terminology and clubbed to as a different category here. So that's what we have. The Bowman's has got clubbed to the epithelial as an epithelial stromal dystrophies, because the phenotype combines not an exclusive epithelial but does have a spillover into the anterior stroma as well. So that's the point one here. The Descemet's membrane dystrophies have also been removed, and they've all come into a simpler classification of what is known as the endothelial dystrophies here. And what is IC3D incorporated? It also has incorporated or given additional inclusion for histopathological images, electron microscopic images, and confocal images here. So these have largely been included for most of the well-defined dystrophies, and these are elaborated nicely in the paper if you would want to pull it up. The third most important is again caters to endothelial dystrophies here. So the congenital hereditary endothelial dystrophy earlier was conventionally classified as type 1 being the autosomal dominant and the type 2 being autosomal recessive. This has changed, so now what we refer to as CHED is only the autosomal recessive CHED. The autosomal dominant CHED, which we used to refer to earlier, now has got clubbed along with posterior polymorphous corneal dystrophy, because the gene associations and the chromosomal identifications are similar. It's only a difference in the phenotypic manifestation of the disease here. So largely now when we look at CHED, it is going to talk about CHED type 2 earlier, which was called the autosomal recessive. So you would find the prognosis for both the graft and the visual outcome being a little suboptimal as you would compare to that of the type 1 earlier classified CHED here. Again, we have certain other factors like the posterior amorphous dystrophy, the epithelial recurrent erosion dystrophies. These are slightly differently classified here, and the Grayson's Willebrand dystrophy is also being removed here. So by and large, these initial few points are what you need to know when you're asked in your Viva how things have changed in terms of dystrophies here. So just a brief touch up on what category 1, 2, 3 and 4 refer to. These refer to based upon the gene identified, the chromosome which has been defined, the clinical features, and the last line again elaborates the certain examples of those here. So category 1 is where the gene is well known, the chromosome is well known, the clinical features have there is no ambiguity in the definition of the clinical features, as you have Fuchs or you have PPCD, that is posterior polymorphous corneal dystrophy. These fall into category 1. Category 2, the gene is not yet identified, though the chromosome has been identified, and the clinical features are largely well defined here. So again, the stromal dystrophies would also fall into these types of 1 and 2 here. Category 3, when both the gene and chromosome is not identified and there's an ambiguity in terms of the clinical features which are described for these patients, and category 4, when all these factors are not well described, then that falls into the category 4 here. Again, this is a comprehensive overview of what are the various dystrophies which are present in the epithelial, subepithelial dystrophies. If you're looking at the anatomical classification or how the morphology of the cornea is involved, you have the epithelial or the subepithelial dystrophies, you have the stromal dystrophies here, you have the epithelial stromal dystrophies here, and the endothelial dystrophies here. So today's the next few slides will talk to you basically only will be on the endothelial dystrophies. I think Anu, you're blocking the slides here. Thank you. So on endothelial dystrophies, we have the Fuchs endothelial dystrophies, the posterior polymorphous corneal dystrophy, the congenital hereditary endothelial dystrophy, and the X-linked corneal dystrophy. So these are the 4 dystrophies. It makes it very simple for you to remember and very simple for you to address or make a clinical diagnosis on these. The Fuchs endothelial dystrophy is one of the most commonest ones here. It can have an inheritance of either sporadic or hereditary, and hereditary cases tend to be autosomal dominant, as is obvious here. You would find an early onset which can occur in the 4th decade or a late onset which is on the 4th decade here, and the genes differ depending upon whether it's an early onset or a late onset. So you have the FECD 1P34 or P32 here, or they call 8A2 here in the early onset, or the FECD 2 to 8 is the genes which has been described for the late onset one. There is a slight female preponderance in, and it is a progressive condition here. So I think the pathophysiology, to not make it very boring, you could go and refer to this here. It affects the endothelial function. There is an onus on the oxidative stress which worsens this condition here, and what is known as the unfolded protein response here. So I'm not going to delve into the details of this here, and this is a clinical picture of how the disease looks on in its early stages, and a patient presents with a progressive blurring of vision, which could be mild initially here, and usually the patient becomes symptomatic with a lot of foreign body sensation and watering in the when he or she wakes up in the morning. So pain, photophobia and watering could be there with associated epithelial erosions here. There have been several ways of how to grade and classify FECD here. So 1, 2, 3 and 4 was one of the earlier classifications, depending upon the area or the amount of guttata which was seen in the cornea here. So when you just have mild, you call it mild to moderate. When you have just confluent central guttata here, and it becomes moderate to severe when the guttata area is larger and the underlying stromal edema is also present. Very severe when the stromal edema has broken into the epithelium, so you have subepithelial bullae, the bullae rupturing and then causing scarring. So that becomes the most severe stages of here. So again, clinical representation for the pictures of these, the stage 1 where you're just seeing the guttata here, the stage 2 when you're seeing early corneal corneal decompensation when the cornea has become edematous here. Stage 3, you have the bullous keratopathy, meaning the epithelium has also got involved in there. And stage 4, when you have the subepithelial fibrosis in these cases. There are other classifications such as the Kratchmers and the modified Kratchmers here, which again talk to you which divided into grade 1 into grade 4 depending upon the number of gutata which you're seeing, but largely this becomes too difficult to count your number of gutata. So a simpler form is to look at the area of the cornea which is involved here. So you have very minimal gutata, it's going to be 1 here, a little more and scattered gutata in the central, it's going to be 2 here. So that's what we look at now, modified Kratchmers here. And you have an involvement of about 2 millimeters or lesser, it's grade 3, 2 to 5 millimeters of the cornea becomes grade 4. More than 5 millimeters is grade 5, and more than we have a large amount of confluent gutata with the clinical edema, then it becomes grade 6 here. So these are the various classification systems which are associated with. And what's new, or what you need to know, is that you can use the pentacam topography to image the posterior corneal layer to look at the isophores here, and where you are able to where these the isotropes are well discerned, then you mean these are conditions where the disturbances in the posterior cornea is minimal, and probably this is not going to be very progressive, and a simple cataract surgery will be visually rehabilitating, and you probably will not need to consider a endothelial transplant of this patient. Again, this is a fantastic paper. It's a recent work here in the last 3 or 4 years here, and that's something which is new, the way we look at the management of FECD and how we use or put to good use the posterior corneal imaging to prophesize the progression of the disease here. Again, most of us are well aware of the light microscopy. The electron microscopy, we do not do it as a routine unless there is a research interest here. You would find a diffuse thickening and delamination of the Descemet's membrane. You would find hyaline excrescences, as you are able to see on this histopathological picture. There will be, the endothelial cells are not defined, they are degenerated, they are thinned out, and depending upon the stromal edema and the subepithelial bullae and subepithelial scarring, you might find those additional features in your histopathology as well here. So that's how the histopathology of a Fuchs looks like, and you probably will need to look at it when you have for your histopathology slides here. Again, ASOCT is now one of the important imaging modalities here. Primarily in early stages of the disease, it helps you to delineate the exact amount of corneal thickness here. So when you do not have a specular, that would be a very simpler way of how you could serially image your patients to look at the worsening corneal edema here, the stromal edema, which can be picked up. Bullae can be seen clinically on slit lamp examination itself here, but here you would be able to see the amount of bullae and the size of the bullaes as well here. So these are some of those pictures. Confocal microscopy, again, is a fantastic tool when you have a diagnostic dilemma differentiating it from PPCD here or with other dystrophies here, and that helps you to, in early stages, you have increased pleomorphism, polymegathism here. The endothelial cell counts can still be normal in these stages, but the qualitative imaging will show the abnormality in these patients here, and you will be able to pick up an early Fuchs in such cases here. Otherwise, you would have very clear-cut pictures as you're seeing here, with the hexagonality being lost in the early stages, with round hyporeflective structures and reflective material in the cells, and the reduced number of endothelial cells here. So that's about the clinical features about Fuchs endothelial corneal dystrophy. We'll move to the next one, which is the posterior polymorphous corneal dystrophy here. There are several alternate names here, but PPCD is what we refer to it in short form here. It can remain asymptomatic for a long period of time, and you'll probably see it only when the patient is presenting for some other ophthalmic problem, because the entire cornea is not involved. Usually you might have focal regions of involvement, and there are different morphological or clinical presentations in a PPCD here. So usually a slowly progressive condition, and sometimes just a simple cataract surgery will work out, and you would probably just need to follow up these patients and see if in the event of worsening is when you're going to offer a endothelial transplant for these patients here. So these are some of the pictures which again are from the internet sources only, so that because it's a very rare conditions, and it's not that I've seen all the 4 types of PPCD here. You have vesicular lesions here. Sometimes they might just get missed as simple opacities here. You could see the vesicular nature of this picture on the left photograph here, and they might have simple gray surrounding abnormalities. This is something which we do commonly, which I have seen very frequently here. It looks like a railroad track kind of an appearance here, which is 2 band or white flaky kind of material, or a band like kind which is present in the cornea here. The differentials here, you would mix it up with the congenital glaucoma with rupture in the Descemet's membrane. So that's something which you'll have to look at when you are looking at a picture like this. Usually these patients tend to be asymptomatic, or only will have a very less fall in visual acuity in such patients here. You can have larger grayish opacities like this as well, which could be mistaken for a viral or an endotheliitis, healed endotheliitis kind of a picture as well. So confocal microscopy really helps you to delineate this when you're looking at these patients. The ASOCT is a fantastic tool where you will find this amorphous hyper-reflective material which are jutting out into the anterior chamber from the posterior. You have a thickened and upper Descemet's membrane, and you have this jutting material. The histopathology is conclusive in such cases with multiple layers of collagen in the posterior surface and fusiform and nodular excrescences, and depending upon the overlying stromal involvement, other features of stromal edema and subepithelial scarring can be made out in these patients here. Confocal microscopy is very characteristic, and you would find such pictures here as you are a donut kind of a picture in these patients has been well described here. Congenital hereditary endothelial dystrophy, I told you the classical one now, which is accepted, which is now described, is the autosomal recessive type 2-1, a diffuse ground glass edema of the cornea, and this is autosomal recessive. So the visual disability is much more in this, associated with nystagmus, and usually presents early on in life in these patients here. You have the Harboyan syndrome, which you could probably get in some of your MCQs here, when it is associated with sensory neural hearing loss here. It usually it presents with grave severity and usually does not progress here. And these children present to you early, and depending upon the amount of corneal clouding, you need to assess if you are able to make out the pupil and the iris structures here, which will help you to decide whether you want to do a full thickness keratoplasty, or if the anterior chamber details are a little visible and you are able to make out you know that you are able to make out the way the graft behaves in the anterior chamber, then you could take these patients on for a DSEC or a DMEC here. So that's how you go about deciding. So these patients, you would probably, these are children, and you would want to take them on for early on for endothelial or for full thickness keratoplasties. In type 1, which would have a similar, the ground glass is much lesser. That tends to be progressive. So that's got clubbed with PPCD right now. And in such cases, you would find the visual acuity being surprisingly much better to the amount of corneal disability the patient is having. So that you would commonly see in a type 1, and it's usually not associated. The autosomal dominant, which has now become PPCD, is a progressive condition here, and you might find worsening of the condition in such patients, and most of those cases will be amenable to an endothelial transplantation as well here. So this is again a very clear-cut picture on your ASOCT, and your light microscopy will show you large areas of epithelial and stromal edema here. The Bowman's is broken in these here, and the endothelial cell loses its characteristic appearance when you see them here. So that's how the endothelial, the CHED looks like. The third one, which is not very common, not most of us have seen them frequently. This is an X-linked chromosomal dominant located to locus XQ25, again a congenital dystrophy here. The males present with more symptoms, had blurred vision, and the females who are carriers are usually asymptomatic with minimal clinical features here. It's usually minimally progressive, and in females it's not progressive at all. So you will just find a congenital corneal clouding. So it can be misdiagnosed with can be confused with a congenital corneal opacity here in these patients here. They might have a sort of a glassy milky appearance, the nystagmus which will present here, whereas in women the classical clinical features are not present, and just you have crater like appearances on the corneal stroma here. This This is the light microscopy which shows irregular thinning of the epithelium, the Bowman's, the anterior stromal collagen lamellae are also affected, and you have thickening of the cornea in the affected regions here. So, the management for all dystrophies, if they are symptomatic, you will categorize them into medical or surgical. So all of them, you would put them onto a medical agent. You would want to put them on sodium chloride drops here, and topical anti-glaucoma medications here. I normally do not use NSAIDs on these eyes here, and probably supportive treatment with lubricants would help. But where you need to visually rehabilitate early, depending upon the visibility of your endothelial graft manipulations on the anterior chamber, which the corneal clouding enables, you will consider doing an endothelial keratoplasty, like a DSEC, DMEC, or a DSEK in such patients. The challenges in pediatric cases doing endothelial keratoplasty, I think Dr. Namrata is taking on keratoplasty later, so she will elaborate more of this. So I'm going to just curtail you to endothelial dystrophies only here. And what is new here in terms of endothelial keratoplasty, which I think I missed adding on this, we also have what is described as SEPA, is from India and South India, the LVP, where you do selective endothelial removal here in these cases. So that has also been described for some cases here, but that's more for pediatric cases of ASDAs and not used for endothelial dystrophies here, even when they are of focal involvement. Cell-based therapies for endothelial replacement is still in its very juvenile stages, and probably can give us a lot of hope in terms of managing endothelial dystrophies in the years to come here. So what you probably need to update for competitive exams is to go and read up a little on cell injection therapies and tissue engineered constructs for management of endothelial keratoplasty, but still it's not largely come into clinical practice and is more in terms of only research stages, which we are looking at here in these patients. Another aspect which you might be asked is the advent of ROCK inhibitors in the management of these cases. What you currently have is commercially available formulations are not enough to take care of your endothelial dystrophies here. So that's the take-home message which you have, and some of them do tend to support your endothelial dystrophies, which are slowly progressive, by using ROCK inhibitors, but the percentages which are required for management for these are different, and they are not available as commercial preparations. The variations in DSEC, DMEC is that you could also do some of these cases without the Descemet's membrane removals. That's called the DWEC. I think more of this on the DSO, Dr. Namrata will be covering in these patients here. So I will just close here with a short video. So here you're seeing the cornea is totally ground glass. You can't make out any of the details in this particular patient here. So you're doing a penetrating keratoplasty, as you can see here. The prognosis for keratoplasty in congenital endothelial dystrophies falls under the excellent prognosis here. So most of the cases, if they fail, is usually because of graft rejection or graft infection. So these need to be followed up closely so that these complications do not adversely affect the results of your cases when you are managing these children with penetrating keratoplasty here. So the other one which is commonly done is the DSEC in such patients. Again, pediatric DSEC is very difficult to position these patients in the postoperative period because you need a supine positioning for 24 hours here. So that's important in these patients. You probably will want to suture all your incisions in pediatric cases. And again, remember, they are small eyes, very small space to operate in, and also that the thickness of the cornea is quite heavy, so manipulating your graft in the anterior chamber becomes difficult in these patients here, and they are phakic eyes as well. So these are particular challenges when you are doing DSEC in pediatric cases here, but surprisingly the visual prognosis and clarity in these patients is much better than an eye in which you have done PK, where the cornea is looking more clearer than as when you would do for a DSEC patients. And when you do endothelial keratoplasties for DSEC, it takes a longer period time to clear rather than what you would do for a DSEC in for a pseudophakic bullous keratopathy. So these are clinical pointers which you will have to which you will look at when you are managing your endothelial dystrophies. I think I'll stop here, and thank you, sir, and Rajesh, for the opportunity to present. Thank you.
Thank you.
I was just sharing with Rajesh, if you have Virat and Rohit, then other batsmen need not to play. So if you want that every one of us should watch World Cup, we should finish before 1:30. Thank you very much. Dr. Beatty, IIM, please.
Yeah, good morning, everyone. So this is a very common condition that all of you must have seen in your OPD. So we need to know what is the correct approach to a case of microbial keratitis. So it includes basically a detailed history taking, clinical examination, investigation, and then followed by treatment. So history would include patients usually come with pain, redness, discharge, photophobia, but you need to ask about their onset, the duration, whether it is associated with diminution of vision, and circumstances surrounding the onset of symptoms. Like you need to know the history of trauma, whether it is due to some vegetative object which would indicate a fungal etiology, or muddy water which will be going towards acanthamoeba. Then you need to know also about ocular surgeries, if the patient has undergone any ocular surgery, any corticosteroid use, immunosuppressive therapy, any contact lens use, any systemic disease like uncontrolled diabetes or autoimmune disorders. These need to be ruled out. Then treatment history. Most of our patients come with a cocktail of drugs being applied in the eyes. So you need to know about the details of the drugs that are being used by the patient when they come to you, and also about ocular surface disorder. Let me carry on. Then history is followed by examination. First, we need to do visual acuity. Of course, visual acuity is usually affected, especially for central corneal ulcers or patients with corneal edema, because the patient can have endophthalmitis, or patient can have iritis, uveitis, cataract, complicated cataract. So all these, even perforated corneal ulcers would cause a diminished vision. Then eyeball examination to rule out proptosis, lag of thalamus. Lid and adnexa, of course, needs to be examined to rule out MGD, entropion, ectropion. These will affect the healing of the ulcer. Then a local source of infections like dacrocystitis and canaliculitis needs to be ruled out. Then intraocular pressure, usually digital examination should be done in these cases. Causes of corneal exposure should be ruled out, like facial nerve palsy, proptosis, ptosis surgery, or lower lid and ectropion. Then examination of the conjunctiva, you need to see the congestion, see papillae, follicles, and rule out any allergic conjunctivitis which may suggest a Shields ulcer. Then chemosis. Chemosis is usually seen in very severe type of corneal ulcers. Then discharge, which can be watery, which is suggestive of mild bacterial keratitis or a viral keratitis. Mucopurulent is usually suggestive of bacterial keratitis. And if it is, if the discharge is of greenish hue, then Pseudomonas probably is the culprit. Then you have to look for dry eye, cicatrization, keratinization, any foreign body, especially in the subtarsal areas. Now, corneal ulcer examination is a very important part of the examination, where you need to see, do a very good slit lamp examination. Here, size, shape, location of the ulcer, like whether it is central, peripheral. Peripheral goes more in favor of marginal ulcers or autoimmune etiology. Then whether it is superior or inferior, or then margin has to be delineated, which is best done with fluorescent stain. Now it can be round, or it can be feathery, or it can be punched out. All different types. It will suggest different types of ulcers. Like feathery would suggest a fungal. Punched out would be a kind of neurotropic ulcers. Then you need to examine the base, the depth, the vascularization, whether it is superficial, deep, or if ghost vessels are there. If there are ghost vessels, or if there are deep vessels, then it is suggestive of probably a chronic viral keratitis. Then any additional feature like presence of suture, dystrophy, thinning, scarring. Corneal sensation is a very important thing, because this also suggests like it is less in viral keratitis, and also is less in neurotropic ulcers, and also it affects the healing of the ulcer. Then you have Siedel's test is done where you are suspecting a perforation where cornea is thinned out. All this needs to be documented, and this has to be done by color coding, and you should know about all the how to document these, and not only the topographic diagram but also the slit diagram should be done so as to know the depth of the ulcer and the height of the hypopyon also. Besides cornea, now we need to examine the sclera, the adjoining sclera, where we have to look for inflammation, nodules. Then involvement of sclera occurs in very severe bacterial keratitis, or it can occur in autoimmune disorders. Then anterior chamber has to be examined for depth. If it is shallow, probably the patient has had perforation. Then cells, flare would indicate iritis reaction. Hypopyon, whether it is mobile or fixed, is important, because a fixed hypopyon indicates a fungal keratitis. And how do you do it? You ask the patient to lie down for some time and then get up. Usually the height of the hypopyon remains static in case of fixed, whereas it decreases in case of mobile hypopyon. Then again you need to look at the iris, lens. Fundus is usually not visible because of the edematous cornea, and the ulcer itself can prevent you from visualizing the fundus. So if patient is going for surgery, then any kind of surgery, then we need to do a B scan for posterior segment evaluation. Fellow eye examination is important especially when you are suspecting autoimmune etiology. Based on these findings, you need to actually grade the ulcer, because this helps in your treatment decision and also for prognosticating the patient. And mild is less than 2. It is based on size, shape, and depth and of the infiltrate, and scleral involvement is there or not. So anything less than 2 millimeter is a mild ulcer with less than 20% depth. Whereas moderate is 2 to 5 millimeter with up to 50% depth of involvement, and severe is more than 5 millimeter with a depth of more than 50% involvement with deep stromal involvement, and there can be scleral involvement also in severe cases. So no ulcer can be diagnosed accurately without microbiological investigation. This is very, very important, because all of us start straight away with drugs, which should not be done. When the patient comes to us, we need to take the samples and then only start the treatment. Okay? So clinical findings only give clues and help to give a differential diagnosis. So what we need to do first in a patient of corneal ulcer is, after taking history and examination, doing the examination and documentation, we need to do the corneal scraping. This is a very simple method. It is done under topical anesthesia with 15 number blade or Kimmerer spatula, or with 26 gauge needle. Scraping from base and margin of the ulcer is done, and the material is sent for staining and for culture and sensitivity. So the commonest stains that are initially sent are for gram staining, JAMSA and QH, and they more or less give the common bacteria and fungi that affect that causes microbial keratitis. But if you are expecting atypical bacteria, then you need to do others like calcofluor white and Zn staining for mycobacterium. Culture is done in blood agar, chocolate agar, sabrot. Blood and chocolate is for basically for bacteria and fungi, and sabrot is for fungi and anaerobic media like the thioglycolate media. Chocolate agar is mainly for fastidious organisms in Neisseria and Haemophilus. So actually only 40% to 73% have been reported to be the culture positivity rate in the literature. So when you say it is positive, when the in the presence of signs of active keratitis, you have growth of some organism, of the same organism in 2 or more media, or there is a confluent growth in one solid media, or the growth of the organism in one media plus positive smear, or growth in a liquid media. So if there is no growth, when you declare it as negative, for aerobic media after 7 days, for anaerobic media after 14 days, and for fungal and mycobacterial culture, it is you have to wait till 4 to 6 weeks before declaring it as negative. So if culture is negative for say repeatedly, you can repeat it for 2 to 3 times, and before repeating the culture, you need to stop all antibiotics, and then for 24 to 48 hours, and then only take the scraping. In spite of it, after 2 to 3 times you're not getting any positive result, then you need to do corneal biopsy, which is done by trophine, and again do the same stain, and you can do the culture. Then in case of certain other investigative modalities are there, like anterior chamber parasynthesis, tissue culture ELISA, PCR, molecular biology, confocal microscopy. The last one is mainly done for deep fungal keratitis and acanthamoeba. You can see the cysts and the hyphae in these cases. So what are the organisms we are expecting? It varies from place to place. In northern India, this is a study which reported that 61% had coagulase negative staphylococcus, whereas in South India, it was streptococcus pneumonia, and equal proportion of bacterial and fungal infections were found. While in East India, it was found that fungal infections were more as compared to bacterial infections, and they also found that Staph aureus was the predominant species. So it varies, it depends on the geographic location also. Treatment modalities will be dealt with in detail by the subsequent speakers, so I'll not go into detail. So basically you have to give, according to the etiology, you need to give the treatment, and you need to give adjuvant therapies also with it, that is cycloplegics, anti-glaucoma, tear supplements and steroids. So what is the indication of systemic antibiotics? These are impending perforated ulcers, large deep ulcers, scleral involvement, endophthalmitis, post-PK or perforating injury. When do you know that the patient is responding to your treatment? When you find that there is decrease in pain, congestion, there is resolution or decrease in infiltration, margins become well defined, ulcer size decreases, there is corneal clarity due to corneal decrease in corneal edema, then vascularization is a sign of healing, then decrease in hypopyon or AC reaction, and cessation of corneal thinning. Now, if the patient does not respond to medical treatment, we resort to surgical treatment. Here, if the perforation is less than 2 millimeters or equal to 2 millimeters, we use glue, various types, patch graft, conjunctival flaps, amniotic membrane transplants. And if it is more than that, if the size is more than 2 millimeters, then keratoplasty is done. Cross-linking, collagen cross-linking is a newer modality which is showing promising results. There are various reports regarding its efficacy. Then other surgeries which are indicated in a case of microbial keratitis are entropion and ectropion corrections, tarsorrhaphy, as the need be. So to summarize, a systematic approach is the key to accurate diagnosis and management. It should include a good history, a detailed history, examination, documentation, microbiological investigation is a must, and then followed by appropriate treatment. Frequent checkups is also important in these patients, and compliance needs to be looked into. Thank you.
Thank you very much, madam.
Thank you.
Now, may I request Dr. Anu Malik to some change? Okay, ask. All topics are very good. All speakers, teachers are learned teachers. And micro teaching in education, not only in medical but in general education, it is being considered that 8 minutes lecture is the best lecture to be retained by the any in the best environment, on the best favorite topic, and the best teacher. Retention is around 30%. So if the lecture is exceeding 8 minutes, it's a negative one. So this probably whosoever has planned this 10 minutes is perfectly fine. 10 to 12 is okay, but we are going 10 to 20. So I would request that we don't make it 20-20, but try to make it 12 at least, not more than 12. Thank you.
Good morning, everyone. At the outset, I would like to thank DOS for giving me the opportunity to be a part of the teaching program today. So I'm going to talk on bacterial keratitis. It is one of the most common causes of suppurative corneal ulceration, and it will be one of the most common clinical entities that residents will see in the cornea clinic, and a very important exam case as well. So the cornea is blessed with a lot of factors which provide resistance to infections, starting from the outermost tear films, which has a number of immunoglobulins, lysozymes, lactoferrins, then nerves. The epithelium itself per se, it has a lot of tight junctions which inhibit the organisms from penetrating. It has got a number of antibodies to the various interleukin receptors, and then the keratocytes and the various immune cells. So originally it was thought that cornea does not have immune cells, but of late it has been proven that there are resident immune cells in the cornea, and a number of cytokines, protective cytokines, which prevent infection. So what is important is you have to identify and treat at the earliest to prevent sight-threatening sequelae. It is a little difficult to estimate the disease burden, and there have been many studies from across the world. Why it is difficult? Because you can make a diagnosis of bacterial keratitis on culture, and culture-proven cases are only in the range of 40 to 70%, as ma'am has said. However, if we see, there have been large cases from RP Center and from Arvind, which have indicated the incidence to be around 25 to 30%. Among all the cases of microbial keratitis. So risk factors in the condition in which the cornea will become susceptible to these bacteria are ocular trauma, and that can be any trivial trauma from soil particle, dust particle, fingernail, cosmetics, anything of that sort. Then contact lens wear and care from contact lens solutions. Then ocular surface disease where the tear film is deficient and the epithelium is compromised, such as dry eye, as you can see in this, where there are a lot of punctate staining of the epithelium. And then in persistent epithelium defects, which may get infected, secondarily reinfected. Then pre-existing corneal pathology like conditions such as PBK and HSV, those corneas are more susceptible to infections. Eyelid and adnexal diseases like entropion with trichiasis, which rub and alter the integrity of the epithelium. And previous eye surgeries such as LASIK, where the epithelium, where there is a flap that is created, so under the flap there can be infection from the blades. And diagnostic eye procedures, even simple things like fluorescence staining that you do, you have to be very careful in the clinic. Among the systemic risk factors, diabetes, HIV, AIDS, immunosuppressed individuals, burn patients on ventilator, and malnourished are susceptible to bacterial keratitis. So in all cases of bacterial keratitis, it's recommended that you do at least a baseline blood sugar and syringing or regurgitation test at least. Pathogenesis of bacterial keratitis, like the organisms can be gram positive or gram negative. So they have the LPS, the gram negative, they have LPS lipopolysaccharide in their cell walls, and the gram positive organisms, they release like the kinases, and they penetrate, they attach to the epithelium, then they go deeper and produce these and then via the matrix metalloproteinases, they attack and cause collagenolisis and cause further penetration. It is important to note that organisms like Neisseria, Corynebacterium, Haemophilus, and Listeria can even penetrate intact corneal epithelium. And there's also concept for biofilms, like especially in the contact lens wearers, where these organisms, they form a protective biofilm around them, and that is how the normal antibiotics, they are not very effective against these organisms. So etiological organisms, the bacteria can be classified as aerobic and anaerobic, and it is important to know at least the names and the broad groups, classification groups, like gram-positive cocci like the Staph aureus, gram-positive bacilli, the Corynebacterium, gram-negative bacilli. I'm just listing the more common ones, like the Pseudomonas, and then you have gram-negative bacilli, then Fusobacterium, and some atypical bacteria such as Mycobacteria and Moraxilla and Nocardia. So there are, interestingly, there are regional variations, and studies from India, the large studies by Dr. Sharma and from Arvind. So they pointed that Coagulase negative Staph aureus was the most common isolated bacteria. And from Arvind, there was the Streptococcus pneumonia, which was the most common bacteria. And similarly, there have been large studies from East Asia and Europe in which Coagulase negative Staph have been found to be the most common organism. In the Americas, there was an earlier study, like from 2000s, where Pseudomonas aeruginosa, probably with the use of contact lens where it was the most common isolated organism. So predispositions also, they have these organisms, they have some important points that we can remember, is that these organisms can also be correlated with the clinical conditions like Staphylococcus species, and they have been found to be more commonly isolated when there's a history of trauma with foreign bodies or dust particles, agrarian suburban communities. Strep pneumonia was found in more when there was a history of dacry cystitis. Pseudomonas, like I said, contact lens wears and hospital diagnostic procedures post-LASIK. Moraxilla, more commonly in immunocompromised and malnourished patients. And Nocardia, when there is a history of trauma or soil particles. And atypical Mycobacteria have been the most common organism noted after refractive surgery such as LASIK. So the clinical course of the keratitis can also give a clue about the organism. So rapidly progressive, if the ulcer is rapidly progressing with suppurative infiltrate, then a Pseudomonas or Staph aureus or Strep pneumoniae infection can be suspected. However, if the keratitis is like slowly progressing, not very aggressive, then you can think in terms of Staph epidermidis, alpha-hematolytic Streptococcus, Moraxilla, and non-tubercular Mycobacteria. Clinical presentation symptoms will be the common like redness, sensitivity to light, diminution of vision, and pain. And there'll be general signs like lid edema, discharge, which may be mild or copious depending upon the organism. And there may be associated conjunctivitis and chemosis in cases of gonococcal, pneumococcal, and Haemophilus. And AC reaction and hypopyon may also be present. So slit lamp examination, there is the clinical, many of us would have access to a slit lamp photography, but there is no substitute for a good corneal diagram in cases of corneal ulcer, where you have to measure the area, density, size, depth of infiltration, stromal edema. Also make note of the sclerin involvement and hypopyon mobility. And these have to be made at every visit that you see the patient, so that you can see how the ulcer is resolving. So this has already been discussed, however, this is important when you, for initiating the therapy, where the ulcer can be classified as mild, moderate, or severe. So specific signs for bacteria, gram-positive bacteria are generally, they'll be well-defined, they'll have distinct borders, and they'll be more superficial, but they could be deep in long-standing cases, and they have a flat profile with a white hue. Whereas, and the gram-negative, they will have more inflammatory component, they'll rapidly worsen, like in the pseudomonas, and they will also be associated with corneal melting. Pneumococcal ulcers typically have the, they're called ulcer serpents, so they will have a creeping course. Moraxilla and Corynebacterium, they are more of indolent, they may be oval-shaped and lie peripherally and be superficial. So typical clinical features can aid you in diagnosis. Atypical organisms like atypical mycobacteria, found only after the LASIK and immunocompromised individual, they have the classical cracked windshield appearance. They have minimal AC reaction, the eye is not red hot, and they have surrounding clear cornea. And why they're a diagnostic challenge is because these mycobacteria, they have negative staining because of lipids in the cell wall. So they might not, you might not detect them on the usual staining, and so you need to do special staining like Ziel-Nielsen. Nocardia is another organism where, and with a very typical wreath-like pattern. So it will be like a circle and hyphae edges elevated, and there'll be a lot of clear spaces as compared to acanthamoeba, in which there will be, it's more continuous, the ring is more continuous, and it's not, there are no clear spaces. The nocardia has been also seen in tunnel infections. And it is a filamentous tender dot line on examination, and have to be distinguished from fungal, which is has more branching pattern, and pythium, in which the hyphae are more flat. Microbiological workup, I think ma'am has covered, so I'm not, I'll not go into the detail. So the KOH and gram stain, you have to scrape all corneal ulcers, and then you have to give them for smear examination and culture examination. Acid-fast staining is important for Mycobacterium, Actinomyces, and Nocardia. Culture medium, very important for residents. You should at least know which organism is best found on which culture media. Corneal biopsy, if there's no clinical improvement and 2 negative smear, then corneal biopsy can be considered. Confocal microscopy does not have a very major role in bacterial keratitis. They're typically not visualized, and what you will see on confocal is only just the inflammation. So broadly, gram-positive organisms are managed with moxifloxacin, gatafloxacin, or fortified antibiotics. Oral antibiotics if the infection is deeper, and for night you can give an ointment. And gram-negative, either the broad spectrum fluoroquinolones, the 4th generation moxifloxacin, gatafloxacin, and of course the aminoglycosides. So monotherapy, if it is less than 3 millimeter, the ulcer does not involve the axis, and combination if it is more than 3 millimeters, like the moderate to severe. And this is the different antibiotics and their preparation, the strength. So all of us should have a certain idea about how to prepare these fortified antibiotics. And the problem, not the problems, but the challenges are that they have a low shelf life, and they're toxic and pH and tonicity, and it has been found that the fluoroquinolones have got comparable efficacy. So what should be the regime? Every 5 to 15 minutes in the first hour, it has to be a very aggressive management. You have to start in the clinic itself, preferably. So in the first hour, it has to be 5 to 15 minutes, which is the loading dose. And then after that, 2 hourly, till you get favorable response or epithelialization, and followed by hourly, around the clock for the next 2 days. And it should be gradually tapered, and even after 2 weeks after healing, you can give to prevent the recurrences. So there are a number of newer antibiotics, and this is mainly because of the resistance that is being reported with the conventional antibiotics that we were in use. So preferably you should be well versed with the names like the linezolid, colistin, piperacillin, and their relative concentrations and how to prepare them. And especially for the multi-drug resistant pseudomonas, the colistin, and for the other gram-negative multi-drug resistance, imipenem is being used. For atypical mycobacteria, the topical is mainly the amikacin, which is 2% to 4% eye drops, and azithromycin oral can be given. And if even after 1 month of medical therapy, it's not responding in a case of refractive surgery, LASIK flap amputation may also be considered. Similarly, for nocardia, amikacin 2 to 4% is the drug of choice. Earlier, it was also sulfamethoxazole and trimethoprim. Then empirical therapy, proper dosing is must, and maximum medical therapy should be initiated. So what is the role of steroids in corneal ulcer? So there was a SCUT trial, and after that there was a Cochrane review. There have been other studies. So in particularly the SCUT trial, the residents should have like a basic idea that there were 500 patients who had received 48 hours of moxifloxacin 0.5% therapy. And after that, the main finding was that there was no difference in the clinical outcomes in the patients who received prednisolone versus the placebo group. And at 12 months, the topical corticosteroid therapy was associated with long-term clinical outcomes in bacterial ulcers not caused by nocardia. And in patients who had less than counting finger close to face or central deep ulcers, there was improvement of about 1.5 to 2 lines, which was noted. So natural history, they can heal by either scarring or can perforate and so these can be the various outcomes or sequelae of the of the bacterial keratitis. Surgical management, I think the other speakers will talk on it. They have to be managed by therapeutic keratoplasty. Meticular dissection of the infection has to be done, and large grafts, sometimes we'll have to do large grafts where a peritomy is advised. One may have to put 24 sutures, and post-operative care should also be very intensive. And tectonic DALK has also been described to be successful in bacterial keratitis. If there is a pinpoint ulceration, you can go for a glue BCL, which provides tectonic support. It also has bacteriostatic effects and arrest keratolysis. And if patch graft you can do, or a Tenon's patch grafts. Flaps and amniotic membrane grafts is mainly for the peripheral melting and desmetocele stage, and not really advised in the active ulcer. Collagen cross-linking is a newer modality which has been found to be effective in superficial infections of bacterial etiology because of the mechanism of reactive oxygen species and increased mechanical strength. So by a good clinical examination, thorough history, microbiological diagnosis is very crucial, and targets and intense therapy for favorable outcomes. Steroids have limited proven role, and surgical management is advised in recalcitrant and worsening cases. Thank you.
Ma'am, thank you very much for completing, and I would advise for future, if you are given 10 minutes, try to finish in 9 minutes. For this lecture, I think 12 slides are more than sufficient, because I have been told that the children, they have the flight also. So I would request, I should not be harsh, but now by force I have to request everybody, including myself, to finish in 9.5 minutes. If I exceed 8 minutes, please tell me, I'll modulate and finish in 9.5 minutes. Every lecture has exceeded 17-18 minutes actually. Time allotted 10. First was 25, then 21, then 18, means we are...
So I'll be discussing about fungal keratitis, though most of the things have been discussed by Dr. Viti Chaudhary ma'am. So fungal keratitis is seen in tropical countries and more in developing countries, and it is 65% of the patients are usually seen in the age group.
हटाएंगे पहले स्लाइड शो
करो फिर वो कनेक्ट करो
वही तो वो फिर हो जाएगा नहीं लेगा वो ऐसे ही नहीं हुआ था अब करो
Okay, thank you. Aspergillus species are the most common worldwide. In South India, 44% of all the corneal ulcers were due to fungi. So in India, the most common isolated organisms are Aspergillus, followed by Fusarium, and then Penicillium. So coming to the etiological classification, we have filamentous septate and non-septate filamentous. We have non-pigmented fungi like Aspergillus, Fusarium, Acremonium, and Pseudomyces. And then in pigmented, we have Carvularia alternaria, Cladosporium, and Dexclera. Then we have yeast, Candida albicans, and Tropicalis. So coming to the risk factors, it can be due to trivial initiating trauma, due to chronic corneal inflammation, chronic ocular surface disorders, chronic allergic conjunctivitis, neurotrophic ulcers secondary to viral conditions, indiscriminate use of topical corticosteroids, post-corneal surgeries, contact lens wears, and systemic factors like immunosuppression and diabetes mellitus. So coming to the symptoms, we have foreign body sensation, redness, increasing pain, and diminution of vision. The general signs appear like infiltrates, which are grayish white or yellowish white in color. The base of the ulcer is often filled with soft, creamy, and raised exudates. There can be conjunctival injection, epithelial defect, and anterior chamber reaction. We have some specific signs like dry, thick, raised texture, feathery margins, satellite lesions, infiltrates, elevated edges, rough texture of the ulcer, gray-brown pigmentation in dementitious fungi, collar button configuration like in Candida, fixed hypopyon, immune ring, and endothelial plaques can be seen. For example, in dementitious fungi, we can see macroscopic brown pigmentation, which is usually related to altered melanin metabolism. Sometimes the pigment is absent due to masking by a more intense inflammatory reaction. In Fusarium, there is deep extension and perforation occurs early. In Aspergillus, it is less severe and not so rapidly progressive keratitis. In yeast, we have a collar button configuration where there is a small ulcer and an expanding discrete stromal infiltrate. Coming to the most important part of laboratory diagnosis, which has already been discussed by Dr. Biti. We take corneal scrapings from the ulcer edge and base. It can be diagnostic as well as therapeutic. Because it breaches the epithelium, which is a barrier to the penetration of antifungal agents. Then anterior chamber tap and corneal biopsy, which is done in cases of deep keratitis and endothelial plaques, and where there is progressive infection that is not responding to medications with negative culture reports. For smears, we have 10% KOH, gram staining, lactophenol, cotton blue, and GMS. For cultures, we have Sabrot, Zextro, Sagar. The cultures are usually positive in 52 to 68% of the cases, and we can see initial growth occurring in 72 hours, but still we have to wait for at least 7 days before culture to be said as negative. So a definitive diagnosis of fungal keratitis on culture can be said if the corneal scrapings reveal fungal elements in smears and the fungus grows in more than one medium in the absence of fungus in smear, or the fungus grows on a single medium in the presence of fungus in smears, or if there is confluent growth of fungus which appears on the inoculated site on a single solid medium. It has been reported that PCR and culture results matched in 74% of the cases within 4 hours. And there is one more modality, anterior segment OCT, where there we can see early localized or diffuse necrotic stromal cystic spaces. There is a study by Dr. Namrata Sharma ma'am on spectral domain anterior segment OCT in fungal keratitis. Thank you, sir. confocal microscopy, where we can see the optical sectioning of almost any material. In aspergillus, we see there is branching at 45 degree. In fusarium, there is branching at 90 degree. And candida, we see oval budding bodies which may develop pseudo-hyphae 5 to 10 microns in diameter. There is a picture of confocal microscopy showing fusarium filaments. We can also go for keratectomy or biopsy. It is indicated when the cultures or the smears are negative. It is usually done in minor operating room under microscope, avoiding the visual axis, and the base is undermined with surgical blade to complete the lamellar keratectomy. Coming to management, antifungal treatment is usually not started as an empirical therapy unless very strongly suggested by the clinical appearance of the ulcer or the mode of injury. But as soon as we get the smear report, it has to be instituted at the earliest. So this has to be, the dosage has to be noted down. Topical antifungals, see, the initial drug of choice is 5% netamycin, which is given initially every hour followed by 2 hourly once infiltrate start dissolving. If worsening is observed, topical voriconazole 1% or topical amphotericin B 0.15% and or fluconazole 2% can be added, along with broad spectrum antibiotics to prevent secondary bacterial infections, along with cycloplegics and anti-glaucoma medications if IOP is higher. Coming to indications of systemic agents, if there is large or deep ulcer along with scleral involvement or endophthalmitis, post-keratoplasty patients and patients with immunocompromised status. We can see the response to therapy if there is decrease in pain, decrease in size of infiltrates, there is disappearance of satellite lesions, or there is rounding off of the feathery margins of ulcer. So there was a study, mycotic ulcer treatment trial 1, to determine if netamycin or voriconazole results in better visual outcomes in fungal corneal ulcer, and it concluded that in fungal corneal ulcer with fusarium species, patients treated with natamycin group had better outcome than those treated with voriconazole group. In MUD2 trial, it was done to study the benefit of oral voriconazole in addition to topical antifungal in advanced mycotic keratitis cases, and it did not provide any therapeutic benefit for advanced mycotic corneal ulcer. Then we have targeted drug therapy in the form of intracameral and intrastromal antifungals, which are given in cases which are non-responsive to topical and systemic treatment, or there is presence of anterior chamber inflammation, thick hypopyon and deep mycosis. We have 5 to 10 microgram of amphotericin B in 0.1 ml or voriconazole as 50 to 100 microgram in 0.1 ml. Intrastromal injections are given in deep keratomycosis in non-perforated corneal ulcer and the ulcers which are non-responsive to conventional topical and systemic antifungal therapy. There is a study by Dr. Namrata Sharma ma'am which comparing the evaluation of topical versus intrastromal voriconazole as an adjunct to netamycin in recalcitrant fungal keratitis. Then there was a study by Dr. Namrata Sharma ma'am to evaluate the efficacy of topical systemic and targeted therapy protocol in management of fungal keratitis, and the TST protocol provides a stepwise treatment algorithm for management of cases of fungal keratitis with varying severity, and it's very important. We start with topical netamycin 5%. If there is no response, we add topical voriconazole 1%. And still if there is no response after 7 to 10 days, we can opt for intrastromal, intracameral targeted drug delivery, both antifungal injections maybe, or we can go for therapeutic keratoplasty. Coming to surgical management, debridement or glue BCL, therapeutic keratoplasty, lamellar keratoplasty, conjunctival flap, or collagen cross-linking, PAC CXL, photoactivated chromophore for infectious keratitis can be done. Therapeutic keratoplasty is usually done in cases which are non-responsive to maximal medical therapy and infectious which are progressing to limbus or sclera. If there is recurrent infection, impending perforation, or there is desmetocele. Some tips to keep in mind, like the size of trephine should leave a clear zone of 1 to 1.5 millimeter of uninvolved cornea. Interrupted sutures are given, anterior segment is irrigated thoroughly, and the affected intraocular structures can be excised, and the topical antifungals are to be continued post-operatively. There are studies saying therapeutic DALC may be a better option than therapeutic PK in stromal confined keratitis. So in cases of recalcitrant fungal keratitis, Posaconazole for assistant infections can be tried along with 0.2 micafungin, and intrastomal voriconazole and natamycin. Moreover, nanoparticles for sustained drug delivery, antimicrobial peptides can be given, and we can go for PAC-CXL or rose Bengal based PDT. So coming to sequelae of fungal keratitis, they can be corneal opacification, secondary glaucoma, complicated cataract, desmetocele, perforation, endophthalmitis, or phthisis bulbi. Thank you. Thank you, sir.
She did not use bonus points.
Next is Shikha.
A very warm good morning to all of you, and I'll be talking about viral keratitis. So viral keratitis is mainly caused by herpetic or non-herpetic group of viruses. The most relevant for us in herpetic group is herpes simplex 1 and 2 and varicella zoster. Among the non-herpetic, what we clinically see most commonly is the adenoviruses. In the interest of time, I'll only be talking about herpes simplex today. So it is a double-stranded DNA virus with a protein capsid and surrounded by glycoprotein projections. Typically, the HSV1 causes infections above waist and 2 below waist. So when we look at the life cycle, the initial infection leads to a corneal latency, and which can recur as an infection, or it can travel through neurons to dorsal ganglia and stay latent there and later can cause a recurrent infection. So when we talk about the ocular disease, it can be basically classified into congenital or neonatal, primary or recurrent infections. So congenital or neonatal are typically very severe. They can have features of microophthalmia, retinal dysplasia, optic atrophy, and chorioretinitis. The primary HSV infections are the usually milder forms. They occur after 6 months of age in a child when there is a decline in maternal antibodies, and usually there is a blepharoconjunctivitis, lid vesicles, and conjunctival dendrites. But what we are most commonly concerned with is the recurrent infections of cornea. This reactivation of virus can occur due to various factors which are all included here, and they could be fever, menstruation, psychological stress, and upper respiratory tract infections. So recurrent infections can occur in one or multiple layers of the cornea, and this is very important to understand because this is how the treatment is tailored, and the rationale of the treatment depends on these involvements. So when it affects the epithelium only, it can occur as a punctate keratitis, which can subsequently coalesce and break down and lead to a dendritic ulcer or a geographical ulcer. The dendritic ulcer is a branching lesion with terminal bulbs, and you need to stain, otherwise sometimes you can miss it on a slit lamp microscopy. Staining is very important to be seen in blue filter light. And after resolution, a dendritic scar may leave a ghost scar in superficial stroma. If a dendritic ulcer is not treated appropriately, if a steroid has been used or in immunocompromised patients, this can easily go into a geographical ulcer. These are identified by their scalloped edges. It is very important to differentiate a geographical ulcer from a neurotrophic ulcer because the treatments are completely different. Then we can have marginal keratitis, which are typically near the limbus, and it is important to differentiate these marginal keratitis which are caused by staphylococcal catarrhal ulcers, because the treatment is completely different for a viral or a staphylococcal ulcer. In viral, you need to put the patient on antivirals, while in staphylococcal, you need to put the patient on steroids because these are immune based. So it is important to remember that an epithelial keratitis is caused by actively replicating virus on corneal surface, and the treatment is rationalized according to this fact. So, but there is another form of epithelial keratitis, the neurotrophic keratopathy, where there is no live virus seen. And this results due to inability of epithelium to deal due to multiple factors. It could be a poor tear surfacing, there could be lack of neural derived growth factors, it could be due to toxicity of antiviral medications and underlying stromal inflammation. So a patient with neurotrophic keratopathy may present to you with an irregular cornea with loss of corneal luster, and there is a persistent epithelial defect. So epithelial keratitis, it can either completely resolve, there could be stromal scarring, or it can convert into a stromal disease, which can again be necrotizing or immune. So a necrotizing stromal keratitis is again due to a direct viral invasion of the stroma. So active live virus is present, and it is mostly seen in patients with multiple recurrences. And how do you identify a stromal keratitis? You may see a dense infiltration of stroma, stromal edema, but what is more important is a usual epithelial defect is present. In contrast, a stromal immune keratitis or a non-necrotizing stromal keratitis is only caused by a retained viral antigen. There is no live virus within the stroma, and a stromal infiltration and stromal edema may be present. A necrotizing viral keratitis is often confused with a bacterial or a fungal keratitis. So you have to look for other signs to identify. You have to see the corneal sensations. You have to see whether the other eye has ghost scars. And then again, history is obviously very important. So a stromal keratitis may then lead to a endothelitis. Endothelitis is again only a delayed hypersensitivity reaction to the viral virus, and there is no active virus present. It can be in the form of diffuse, disciform or linear depending on the pattern of endothelial dysfunction. There can be associated keratic precipitates and underlying epithelial edema. Iridocyclitis may also be associated with endothelitis, and it is identified by fine keratic precipitates and anterior chamber reaction. You may see posterior synechiae, and in these patients, measuring the intraocular pressure is important because that signifies trabeculitis. So there are some posterior segment complications of HSV like CME, epiretinal membrane, retinal fibrosis. So the diagnosis is mainly by clinical examination. We have a multitude battery of tests, but these tests are usually cumbersome to perform, and the time taken for diagnosis through these tests is too delayed to be of practical use. So when we come on to the treatment, we have a number of medications. We have acyclovir, which is available both in topical and ointment form. We have ganciclovir, valacyclovir, and famciclovir. Of all the above, acyclovir is most easily and commonly available in our setup. So this is the most commonly used medications. For an epithelial keratitis, as already discussed, since it is caused by active virus particles, so you only need to give a topical antiviral. And sometimes when the ulcer is slow responding, a gentle debridement may help. For a stromal keratitis, for non-necrotizing forms where there is only antigen and no live virus, you need to give topical steroids along with simultaneous antiviral prophylaxis. Now, in the stromal cases, an oral antiviral is usually preferred because of the better bioavailability and also because the long course of treatment which is required, and where topical antivirals can lead to toxic conjunctivitis and keratoconjunctivitis. However, in the necrotizing form, you need to give aggressive systemic antiviral therapy. This is usually given in the therapeutic doses. That is to say that oral acyclovir is given 400 milligram for 5 times a day, whereas in the non-necrotizing form, we can only give it for BD dosage. So along with the oral antivirals in necrotizing viral keratitis, you also give a topical steroid, but it is in much lower frequency as compared to a non-necrotizing viral keratitis. So the treatment for neurotrophic keratopathy, as already discussed, there is no live virus, and the basic principle is to give surface support. So you have to minimize all topical medications. Preservative-free artificial tear supplement needs to be given. In refractory cases, you may need to put a bandage contact lens, amniotic membrane grafting, or a tarsorrhaphy. So when we talk about the surgery, surgery is often done as a therapeutic measure for non-healing ulcers or for impending perforation, where we can go in for a TABCL or Tenon's patch, and for optical purposes, penetrating keratoplasty or DAL can be done. But it is important to wait for at least 6 months after an active viral infection, and usually we start the prophylactic acyclovir before surgery. These prophylactic doses have to be continued for at least 1 year. The rationale for which is they say that the maximum number of recurrences post-surgery occur in the first year. And if the patient is on prophylactic dose, it decreases the percentage of recurrence to 0% at 1 year and up to 5% at 2 years. So the risk of reactivation and subsequent rejection of the graft decreases with prophylactic acyclovir. For cases where visual potential is not there, a conjunctival flap can be used for chronic inflamed keratitis and patients with medical contraindications for surgery. I think I'll stop here in the interest of time. Thank you. So it is a whole lot of things. I'll go on to varicella zoster and adenovirus then. So there are many slides. Thank you.
Now I invite Dr. Rajesh Sinha on his lecture on keratoconus. Dr. Rajesh Sinha doesn't need any introduction. He is an stalwart in Indian ophthalmology, great teacher and human being. Has done wonderful job in both the fields and in the AIIMS. And Rajesh, if you have any time limit, just take two bonus points.
Thank you. There are a lot of things written in the books about keratoconus, so I'm not going to tell you each and everything. Obviously, it can't be told. So I'll be focusing on salient points that you should remember so that you can diagnose a case of keratoconus, so that helps you in exam as well. And yeah. So what is keratoconus? Keratoconus is a progressive ectatic disorder of cornea, and that results in corneal irregularity, and because of that there is diminution of vision, and many times it is not correctable by glasses as the keratoconus advances. So the best management can be done if you detect it early. How can you detect it early? If you have the highest degree of suspicion. Without that, you will miss a case of keratoconus when you are just routinely examining. And suspicion comes from what? Comes from certain symptoms that the patient says, and topography. What symptoms? There can be many, but frequent change of glasses is a very important symptom. Frequent change of glasses, somebody who is about 50-55 years of age, can be because of cataract, because of open angle glaucoma, but at the age of teens, like 15, 16, 17, it can be because of refractive error and because of keratoconus. But if it is not improving with glasses to 6/6 and crisp vision, then that is definitely keratoconus. And of course you have to investigate. One investigation is a sort of a routine examination, and that is refraction. Refraction has always been underemphasized. We keep talking about big instruments, pentacam and other things. But the first and foremost thing is refraction. You will get a scissoring reflex in that, and that will give you a hint that it is a case of keratoconus. Then of course you have a Placido-based topography and some tomographers. Now there are certain guidelines, there are certain rules based on which you diagnose a case of keratoconus on Placido-based topography. like if the central corneal power is more than 47.2 diopters, if there is inferior superior asymmetry, oblique astigmatism more than 1.5, asymmetric bow tie pattern, skewed radial axis more than 21 degrees. Now what is this asymmetric bow tie pattern? See, you get two bows of when you do this topography, you get two bows like this. Now when you draw a when you draw a line along the two bows, the angle between this is the skewing. Now any degree of skewing like 5 degree, 10 degree is okay, but if it's more than 21 degrees, then this is a suspicious sign, and that is a sign of keratoconus. Then of course pentacam is the modality these days which is most often used to diagnose case of keratoconus. You get a quad map. I will not go into details of this due to paucity of time, but you get a quad map, you get a Bellin-Embraccio enhanced ectasia display, and based on these you diagnose a case of keratoconus. If there is nothing very much like keratoconus in the pentacam, and the patient has a family history of keratoconus, you should also do anterior segment OCT for epithelial thickness mapping, because that is the earliest thing that happens. And if there is a thinning in the inferior part, inferonasal or inferotemporal, as far as the epithelial thickness is concerned, as you can see in this case, upper part it's 70, 67, 64, but lower part it is 48 and 52. That means that it is a case which can progress to keratoconus, a big no to refractive procedure, and of course you have to follow up these patients diligently. And of course biomechanical stability is also an important feature these days which has come up, and values of CBI and TBI, if these are more than 0.5, then that is suspicious of keratoconus. So the aim of management, since it's a progressive disorder, the arrest of progression is the main, and of course next is visual rehabilitation. Now arrest of progression, for that you should know what is progression. Now these are the features that suggest that keratoconus is progressing, and there are multiple features actually. So people just kept thinking that how to simplify this. So there was a global consensus that was formed in the year 2015, and there they decided that if we have these three things, 2 out of 3, then we will consider it as a progressive keratoconus, and that is progressive steepening of anterior corneal surface, progressive steepening of posterior surface, and progressive thinning. And if there is progressive keratoconus, corneal cross-linking is the procedure that is done. How it is done? You debride the central 7 millimeter of epithelium, and after debriding the epithelium you put riboflavin every 2 minutes for 30 minutes, and then after that for the next 30 minutes you focus UV rays on the cornea, keep putting riboflavin, and this is a 1 hour procedure that completes collagen cross-linking. Now it is an established modality now for progressive keratoconus, and there are some good reports, many reports in the literature that has shown that it works very well in keratoconus, and the sign that suggests that it has worked is the presence of this demarcation line. This is the demarcation line, and it suggests that above this line the cross-linking works. So this means that the cross-linking works in the anterior 2/3 of the cornea. There are certain issues as far as cross-linking is concerned. Patient can have pain because you debride the epithelium. It's a long duration 1 hour procedure, and in thin corneas there is risk of damaging the endothelium. So people thought that let's not debride the epithelium and let's do transepithelial CXL, but it doesn't work. So the idea is that in order to get efficacy, you have to debride the epithelium. People have done some crisscrossing, etc., but nothing works. Then in order to reduce time, people started doing accelerated cross-linking, and this is based on the Bunsen-Roscoe principle. So 3 milliwatt per centimeter square into 30 minutes was converted to 30 milliwatt per centimeter square for 3 minutes, and that is how there were different protocols. So studies have shown that 9 milliwatt per centimeter square for 10 minutes is nearly similar as the conventional cross-linking, which is 3 milliwatt per centimeter square for 30 minutes. Then again, in a thin cornea, if it's less than 400 microns, then the risk of damage to endothelium is there. So people thought that let's swell it by use of hypoosmolar riboflavin. But that has nearly 50% efficacy as the conventional cross-linking. People have also used contact lens to bring about a separation of UV rays to the endothelium, but that also doesn't have that much of efficacy. We have implanted lenticule in order to do cross-linking. We at RP Center just created a pocket. Femtosecond laser was used to create a pocket in the cornea, and this pocket was dissected, and riboflavin was put into the pocket, and then a donor lenticule of 200 microns was inserted into the pocket. And then once it was there, cross-linking was done. So we have found out that the results are reasonably good, but here you are implanting a lenticule, so you will have two interfaces. So the risk of interface haze is there. So you require a long-term steroid for this. Another modality, another I would say advancement is in the field of customized cross-linking. People have used higher power for thinner areas. Like if this is the cone, so here there is more red. So here you will use more power, and in the peripheral part you will use less power. But still it is under investigation. People have also used oxygen supplementation because it has been seen that oxygen concentration in the stroma goes down to 0 after 1 minute of exposure to UV rays. So people have used oxygen supplementation. We have also done a study. We found out that the Kmax reduced significantly between the oxygen supplemented and non-supplemented, but it is still in investigative stage. I won't go into details. As far as visual rehabilitation is concerned, contact lens is the mainstay, and rigid contact lens, RGP contact lens, rigid gas permeable contact lens is the mainstay of management. The SOPER is the bicurve design which was used earlier. Now multi-curve design rose scale lens is being used. And the end point of fitting is good centration, movement and coverage. And the fluorescein pattern should show 3-point touch. So you can see one point is in the center, one is mid-periphery here, one is mid-periphery here. So this is the 3-point touch. And this is how it should look like when you are fitting the contact lens. With each blink, the lens should move for 1 to 2 millimeters, and it should come back in its position. There should be nice tear exchange. This movement is required for tear exchange. And some patients are not intolerant to they are intolerant to RGB contact lens. So you can put a soft contact lens and over which you can use a RGB contact lens. So this is called piggybacking. You can also use a hybrid contact lens which has a central rigid and the peripheral soft skirt, and a miniscleral contact lens for a large cone in keratoconus. Intrastomal ring segment has also been used to reduce the astigmatism in cases of keratoconus. So in this, what you do, you create with the femtosecond laser, you create the pocket into which you use PMMA rings. You implant PMMA rings in these two pockets, and it reduces the astigmatism as well as some degree of spherical error. This is how it looks like in the post-op period. And you can also use for remaining refractive error, you can use a toric ICL. Keratoplasty is the last resort. Of course, earlier we used to do penetrating keratoplasty for everything. For any case of keratoconus, we used to do a penetrating keratoplasty. So this is a full thickness keratoplasty. We know that the risk of rejection is higher if you do a full thickness keratoplasty. So these days, we mostly do a anterior lamellar keratoplasty for keratoconus. So big bubble DALK is the procedure which is done frequently in keratoconus. So you create a bubble over the desmase so that it separates the stroma from the desmase, and then you cut the stroma and remove it and then put a lenticule over it. So you cut the stroma, you leave the desmase and the endothelium of the patient, and then you put a lenticule. Sometimes in a healed hydrops, if you create a big bubble, then it can open up the scar or the desmase tear. So you do a layer by layer dissection and then you complete the procedure. The point is that anterior lamellar keratoplasty is the mainstay now as far as keratoconus is concerned. And just a word about acute hydrops. Sometimes you will have a sudden loss of vision because of acute hydrops, because of a desmase tear through which the aqueous seeps into the stroma. So then in that case, you use intracameral gas or you use compression sutures in order to resolve case of acute eye drops. So keratoconus is a disease wherein corneal irregularity is there. The aim of management is to arrest the progression and to mask the irregularity by means of contact lens or by means of any corneal procedure. Thank you. Any question if you have?
Thank you very much, Rajesh. It's mesmerizing lecture. Wonderful.
I'm sorry for my voice because I'm having URI and
His voice is perfect and very loud, crisp and clear. You said all everything. Your lecture.
No, I'm full.
Definitely 10
I'm
out of
full
10.
with medication and
The concept of lenticule
sir.
to place inside is wonderful. Let's see how does it behave in long run.
Sir.
Wonderful, innovative and excellent presentation.
Dr. Rajesh.
Yeah.
Like a non-progressive keratoconus and having cataract, choice of IOL and what will be the management?
Uh,
In a case of keratoconus? Non-progressive keratoconus. Having cataract, what will the choice of IOL and the management? It depends on the age of the patient. Sometimes, say 50, 55, 60. Then in that case, in mild to moderate keratoconus, you can use a toric implant. But if it's a moderate or moderate to severe, then it's better to put a spherical monofocal lens, spherical lens, because in any case for good vision, you require RGP lens over that. And RGP contact lens doesn't work if you are putting a toric lens, because toric lens is being put to cover up for the cylinder, but then the corneal cylinder is still there and that causes irregularity. And the RGP lens mask the irregularity of the corneal shape. So that's why in a mild keratoconus or mild to moderate, yes, toric can be implanted. Yeah, just I wanted to share, like I had a case of keratoconus, like moderate, which was not corrected by the glasses. So I put a Adolph lenses in that. And over that, because he was already using mini scleral lenses. So Adolph lenses plus mini scleral, he's happy, and 6 and 6, like both eyes. So This must be a case of a mild or mild to moderate. It's a moderate, like not corrected by glasses. Okay. Not corrected by
3 years ago, I had a case bilateral keratoconus, around 55 years, from Jammu, and we had a customized IOL, got it especially from Europe, and the testing mechanism was around -8. And he responded well. He's regular in follow-up.
I agree. Like customized IOL being made by the care group also.
No, I didn't want to take the name, but it was not from the care group.
Saying,
that's why I said it was made from the Europe.
Like I had a patient like keratoconus, so I tried customized IOL. She was a lady, so customized IOL around -6. She responded. She had a 6/12 vision, but the other one I am saying. Yeah. So he was quite active. He was a commissioner. He was a like in a bureaucrat. So the teaching is this, that progressive keratoconus we should not put a toric lens. That's what, and plus if there is like he is around 60, so I tried. Earlier I got customized, that's because it's going to crack inside, not outside. So put a Adolph lenses over and above mini scleral, because he was already used to mini scleral lenses. So he's very happy. Like so these options, like just sharing. Thank you. Yeah, but for all the students, it's basically if it's a mild or mild to moderate and the patient is having cataract, you can use toric IOL. But if it's a moderate to advanced, in that case the irregularity is so much that he may require RGP contact lens later. So it's better to put a spherical lens, monofocal lens, and you can manage further with the RGP. And most importantly, these patients are used to using RGP lenses. See, they must be using for last almost 25-30 years if they are 55-60. So they prefer using, and it's better to put a monofocal spherical lens.
I invite Professor Namrata Sharma for her talk, and I have no words to. I think I am not so competent to say a few words about her. Wonderful person, and we started our advanced corneal journey together in mid-90s. And that I want to tell you that you have the wonderful teacher coach here. There are 100 odd students, but all hundreds they will perceive in a different manner. The same coach has trained Kambli and Tendulkar. Tendulkar got Bharat Ratna and world record, and Kambli has vanished. So we, both of us, were trained by the same coach. So where is she stand now? That shows that what is her dedication, commitment to the profession and academics. Professor Namrata Sharma, please.
Thank you so much for those kind words. It is always a pleasure to be standing on the platform of any teaching platform and interacting with the students. I would be talking to you about lamellar keratoplasty. Little bit has been covered in the previous topics. And also be touching about the concept which is now prevalent, and that is the component surgery of the cornea. There are no financial or proprietary interests, and this is the whole jargon of abbreviations that we have, the PTK, SALC, ALTK, HALC, DALC, TILC, DSEC, DMEC, PDEC, DSO or DVEC, and FALC. So we've come a long way from penetrating keratoplasty, which used to be a full thickness procedure, a time-tested technique for last 118 years. We all are very familiar with it. How many of you have seen lamellar keratoplasty? Okay, so fair number. But we are also familiar with the problems thereof, which include suture-related problems, persistent epithelial defects, infections, even if in a seemingly clear graft, post-PK astigmatism, and the patient doesn't gain vision. And I want you to have a look at this, because I myself saw this after 17 years into being cornea, a full thickness penetrating keratoplasty from which the button is removed. And then following this, there is expulsion of the contents, including the retinal detachment, the expulsion of the intraocular contents, and a full-blown expulsive hemorrhage. That is why we are talking about the lamellar procedures, because it is not an open sky procedure. And it is a closed procedure. It is a extraocular procedure, unlike a full thickness penetrating keratoplasty, which is a intraocular procedure. So we've moved on to the customized component surgery of cornea, where for anterior corneal opacities we do anterior lamellar keratoplasty, which is a ALTK. For mid to posterior stromal opacities we do a deep anterior lamellar keratoplasty, and for diseased desmoid membrane endothelium we either do a DSEC or a DMEC surgery. So when we did manual lamellar keratoplasty, there were problems of interface haze and problems of interface debris. So this instrument actually changed the way we look at lamellar keratoplasty, and this is the automated lamellar therapeutic keratoplasty. It is technically, when you do this, is easy, less time consuming, there's smooth host donor cut, thickness is nearly exact, and there are no interface problems. And it can be done for conditions such as this: keratoconus, Salzmann, various kind of anterior dystrophies, and even anterior degenerations. So essentially what is done in this is that the corneoscleral rim is taken, put on the artificial anterior chamber. This is a 500 microns, which is being split into a 350 anterior part and 150 posterior part. And herein is a keratoconic cornea, where again the diseased part of the cornea is removed, and the donor button is taken from the donor cornea, and then subsequently the dissection is done here, so that using a disparity of 0.25 millimeters or using no disparity at all, you can just suture it and get that keratoconic cornea to flatten. There is an interface which is present here, but this interface is quite clear, unlike a manual interface which is quite hazy. These are some of the cases of healed keratitis, Salzmann nodular degeneration, and keratoconus where ALTK was done. And if you look at the results, the best corrected visual acuity in 70 to 90% cases is better than 612, and the astigmatism is less than 4 diopters. Now you can go sutureless also, especially if the opacity is a little anterior. So here this patient had a cataract as well as spheroidal degeneration, for which the anterior lamellar dissection was done with the help of the microkeratome, and then subsequently this is the graft which is being used. So if you're 250 microns or less, then you can go sutureless and not suture it. This is a wonderful publication by Professor Tushar Agarwal from our center on this. Then we have what is called as HALK, or hemi-automated lamellar keratoplasty, where half of the dissection is done manually and the other half of the dissection is done with the automated microkeratome. So this recipient, because it is irregular, is dissected manually, and the anterior part is done with the microkeratome. Then we come to deep anterior lamellar keratoplasty, the gold standard of which is the big bubble Unver technique. There's maximum removal of the diseased tissue. The Descemet's membrane is smooth graft fed and there's virtually no interface. You can do in other ectasias, stromal dystrophies, as well as ocular surface disease. And because it's DALK, you can use a poor endothelial quality tissue. And generally, a backup good quality tissue should always be there. So this is Dua's layer, which is present just above the Descemet's membrane, and if your air bubble goes above this, then it is a type 1 big bubble, which is rough. If it goes below this, then it is smooth surface, and it is a type 2 big bubble, and it's a smooth surface. This is to show how a big bubble DALK is done. So first 60 to 70% trephonation is done, followed by the nick, which is given in the overlying stromal layers, and this can be determined on the intraop OCT microscope that it is supradescemet's, and as soon as the air egresses out from here, the air you can see is egressing out, and the Descemet's membrane is marching in a live show towards the overlying stromal layers, and you know that you've reached the correct plane. Now, subsequently, in this, the excision is then done with the help of the Vanna's scissors over this viscoelastic cushion. And this is the bare Descemet's membrane which is staring at you, and you are extraocular without entering the anterior chamber at all. So this is our longest, one of the longest follow-up. Now more than 15 years after DALK, still doing well with 6/9 and 6/12 visual acuity, a case of Hurler syndrome. And these are some of the cases of DALK with good results. I think this I will skip because Dr. Rajesh has already shown that we can do DALK even in cases of healed hydrops, and the scar shifts to the periphery, so the patient still sees well. These are again some of the cases in chemical injury DALK, and this is after a slet post DALK, and in a desmetocele also you can do DALK, and this is again a one-eyed boy who's now an engineer with a visual acuity of 6/12 and has this as the only seeing eye and still doing well. Then we come to peripheral corneal ectasias, which could be a keratoglobus, and in this Professor Vajpayee from our center, who's been a mentor to so many of us, has described a technique of tuck-in lamellar keratoplasty, and this is basically how it is done. So the partial thickness trephonation is done first, and this is followed by the dissection of the the anterior layers, and then a pocket is made all around, which is 360 degrees. Subsequently, the donor tissue is then dissected, and peripheral 0.5 millimeters of this is removed because this will help you to tuck in. And then the AC paracentesis is done, and the graft is placed onto the recipient bed after doing the AC paracentesis, so that the increased curvature of the cornea, it decreases slightly, and then this is subsequently sutured. So you can, for pellucid marginal degeneration, also do flange, which is only not sectoral, which is not completely circumferential, and this is the result in case of PMD in partial thickness stilk, and this is when you do it in cases of keratoglobus or large keratoconus. This was a case of post-RK ectasia for which tuck-in lamellar keratoplasty was done, and the you can see that the astigmatism has dropped tremendously. Now coming to posterior lamellar keratoplasty, DSEC and DMEC, which essentially replaces the diseased Descemet's membrane and the endothelium, is done for cases where only the endothelium is involved, such as is shown here: bullous keratopathy, Fuchs, failed PKP, eye syndrome, CHED, and corneal decompensation due to various causes. The advantage is that it allows you faster rehabilitation. PKP it rehabilitates in 12 months, DSEC in 3 months, and DMEC only in 1 month. So again, basically the donor cornea is mounted here onto the artificial anterior chamber. The splitting of the cornea is then done, and what remains behind, what remains posteriorly, is what is going to be used for DSEC. And when you do a single pass technique using 400 microns of microkeratome, then you do ultra thin DSEC, and ultra thin DSEC is essentially less than a DSEC lenticule, which is less than 100 microns. So there are various ways of putting this DSEC lenticule in the anterior chamber. This is a case which was actually referred for penetrating keratoplasty, but in this the hypertrophic epithelium was removed, followed by the removal of the scarred Descemet's membrane, which was stained with the trypan blue dye, and this is a descemetorrhexis which is being done. Now this patient also had a cataract, so cataract surgery is also being done after staining it with the trypan blue dye. And subsequently the DSEC lenticule is taken, is loaded onto the Buson's glide, and the graft is pulled intracamerally inside the anterior chamber, and air bubble is then instilled. Now this graft is also doing well with the visual acuity of 612, so you didn't have to do a full thickness penetrating keratoplasty even for this case, and got away without sutures and essentially with a posterior lamellar graft. Of course, with the intraop OCT microscope, it has become very easy to see where these grafts are, as you can see it here, and air bubble can be instilled, and it also helps you to titrate your last step better and see whether the graft is quite stuck to the back of the cornea or not. Now, this is how ultra thin DSEC looks like. Again, you can actually not see where the graft is, it is so thin. This is something we've published, used one donor cornea for 3 recipients. So anterior part for ALTK in keratoconus, DSEC in a pseudophakic bullous keratopathy, and the limbus being used for limbal stem cell deficiency. And sometimes you can't use the limbus because it is from an older donor, so you can use one cornea for 2 recipients. And this is a case of keratoconus, DALK, and DMAC, which has been done for a case of Fuchs dystrophy. Now, I think DMAC is the one which is most physiological graft, and this is how it is done. The trypan blue staining of the Descemet's membrane is done, and this is then from all sides it is detached. The trephination of the central part is then done. The peripheral part is removed, and this is the central physiological Descemet's membrane graft, which is then harvested. Now subsequently, this is a case of Fuchs dystrophy with cataract. Cataract surgery has already been done. The descemetorrhexis is being done just as you would do in a DSEC case. And then the graft is taken inside the injector and is placed intracamerally, and suture is applied, and then you tap. Now you have to look at this biceps curl upwards. So when you get this kind of a configuration, means the endothelium is down. This is upside down because it's not biceps curl upwards, it is downwards. So you tap, 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 or you inject fluid. Now you get it upwards, and then you know the endothelium is looking down, and then inject air into it, and you know that the graft is stuck to the back of the cornea. So this is the post-op day. This is the picture in the post-op period, and this is how it looks like. Now 6/6 at week 1, sometimes even I can't make out that there's a graft, and I have to look at the edge of the graft again. These are again some of the cases, DMAC in hazy media, which clears up over a period of time. Again, we published this. Then DMAC in eye syndrome, again, does well in these cases, and DMAC in shed, which I think I'll skip because Dr. Vanity has shown you. But then the results are really very gratifying, especially in shed cases, because these are children, and the grafts have to last for a longer period of time. And if they look like this without having to place sutures, then you feel it's worth it. Now I am showing this PDEC because this is something which we really don't see, but I think it has a role to play. In this, the big bubble is made in the corneoscleral rim. A big bubble is made here, and the trypan blue dye is injected, and subsequently this graft is dissected after bursting the bubble with the help of the Vanna scissors. The advantage of this is that it has, it's a splintered graft, so it doesn't misbehave like a DMAC graft, which is a very flimsy graft. This is a splintered graft, and also the other advantage is that you can use even the younger donors, because for DMAC you need donors which are more than 40 years, otherwise it will have a very tight scroll and it will not unroll. So this was again hypertrophic epithelium which has been removed, and desmetorexis, the principles of the posterior lamellar keratoplasty remain the same. This is the PDEC scroll which is being taken, and again you place it and notice it's a graft which is very friendly. You can actually maneuver it, manipulate it inside the anterior chamber. I do feel there's a little more endothelial cell loss, but then you can use younger donors. You can use infant corneas. You can use donors which are, young, and so the endothelial cell counts are going to be higher. So this is PDEC where epithelial defect is still present, but does well as is seen on the anterior segment OCT also. This is the last bit, the biomaterials for corneal endothelial cell culture and tissue engineering. We are working with our international collaborators on this, and this is something which I think we should all look forward to, and that is the biosynthetic cornea. So in this, with the help of the femtosecond laser, a pocket is made, the pocket is subsequently opened, and the biosynthetic cornea, which is made from the porcine collagen type 1, with a recombinant technology is placed. It looks pretty much like your soft contact lens, a little more rigid than the soft contact lens. This is folded and then is unfolded intrastromally inside. So I think this is something which we should look forward to, and we are trying to grow endothelial cells on this so that now we have a stromal construct, but we are looking at a complete construct with endothelial cells. So these are the books on corneal transplantation, DALC and DSEC. We've come out very recently with the 3rd edition of corneal transplantation, thanks to Professor Vajpayee for initiating it almost 25 years ago. And these, you are all familiar with Professor Praful Maharana, who is giving an interview right now, but has done wonderful books of ophthalmology clinics. So thank you very much for your kind attention.
Thank you, ma'am, for a very nice and comprehensive coverage of the various lamellar keratoplasties. Thank you very much. Any question for her? And if there's no question, then it's my privilege to invite a doyen in the field of cornea and eye banking. We have Professor Brigadier J.K.S. Parihar, who will be talking on eye banking.
Thank you very much, Rajesh. Thank you very much.
He's the president of Eye Bank Association of India as well, and has worked, has a huge contribution in the field of cornea, in the field of eye banking. And it is essential for all of you to know about eye banking as well, because corneal transplantation depends on eye banking.
Thank you very much. Good afternoon, my dear younger friends. And I always mention that the difference between you and me is only one, that I was born quite, I think, 30 years, 40 years before you would have born. But another difference is that I had no access to all YouTube's, internet and all those things what you have. So you are better trained. You have a better teacher than me. My teachers, obviously, because now you have a teacher like me and Namrata. So with this background, for the postgraduate students, medico-legal aspects are very important, and community ophthalmology, and in some time in some various universities, paper 4 may have related with this particular concept of eye banking, corneal transplant acts, and so many other national programs. So you must, these are very dry subjects for the PGs, and they must read these things with, because you will have questions from them on these topics. If we go with the corneal blindness, the exact figure is not known to us, but it is estimated by different surveys, and prospective analysis later on that around 1.3 million corneal blinds are in India, and most of majority belongs to the children. That is very, very alarming situations. If we go with the common causes of corneal blindness, infection, injuries are the most common, and then it comes to the complications following eye surgeries. Thanks to newer machines and experience in our society, this particular group is becoming shrinking now. And then we have the dystrophies, which is coming as the keratoconus we have discussed, but the most common remains infections and the injuries. If we go by the concept of the eye banking, it is all based till the Professor Namrata is successful to give us the biomedical engineering associated corneal, artificial cornea. It all activities are based on to harvest the cornea and other part of the eye for this therapeutic purpose. We have almost 11 million deaths occur every year in our country, but we have only roughly less 60,000 eyes are donated, and number of corneal transplant is 35 to 40,000. So definitely there is a huge gap which is there. In our country, the act has been enacted in 1994, the Transplantation of Human Organs and Tissue Act, which was gazetted on 8th July 94, and this act is to provide for the regulation of removal, storage and transplantation of human organs and tissues for therapeutic purpose and for the prevention of commercial dealings in human organs and tissues, and for matters connected therewith with incidental thereto. However, this particular act has a lacuna where the cornea was considered as good as any other organ transplants like the liver, heart and kidney transplant. So we had so many restrictions to what we have been practicing before this act was grossly affected. And I remember then that we had a presentations before Parliamentary Standing Committee, myself and Radhika from EVI, and thereafter we had an amended act on 28 September 2011 where the cornea has been labeled as a tissue, and now the trained technicians may enucleate cadaveric eyes. So these are through acts, the tissue separated from organs and tissues in terms of requirement of infrastructures, equipment and human resources for retrieval, storage and transplantation, thus making registration under the act is now simple. The act is now called the Transplantation of Human Organs and Tissues Act, and registration under this act is mandatory to establish an eye bank or the practice corneal surgery. You as a ophthalmologist, MS or DNB, MD, you can practice all kind of ophthalmic surgery. There is no legal restrictions whether it is a oculoplasty, VR or anything. But for corneal transplant, there is a restriction that you have to be registered with the state authorities, and for that there are some prerequisites, training, observations and independent surgeries you have performed under supervision and independently, then only you are being registered. So you please remember this particular part. And even if you are a trained surgeon, like I am a trained surgeon, but when I have joined some other institutions, it has to be ensured that I cannot perform the surgery in that institution unless until particular institutions is being registered as a cornea transplant center by the respective state authorities. It's very, very important. Otherwise, you may be liable for so many litigations, and this comes under IPC. So medical legal aspects of medical practice is very, very important. You have recently, last 2-3 days, there is some nursing home where a technician was performing the surgeries. So one must remember that you have to know about the rules, regulations and follow them with great spirit and practice. Now what do you understand by the eye bank? Is a community non-profit charitable organizations dedicated to restoring the sight to those who are blind or visually impaired through the promotion and advancement of eye donation. This photo I deliberately put it there is of somewhere of 2000, and in the white you have the father of Indian ophthalmology, Dr. S. Badrinath. So my rich tribute to him for his contribution. And what is eye bank? The eye bank is the link between the donor family and a cornea recipient. how the eye bank functions. As I mentioned, it's a link between the donor family and cornea recipient to procure quality tissue through voluntary donations or hospital cornea retrieval program, to screen eyes as per the eye bank standard, to evaluate the tissue, to test for the HIV, hepatitis and other requisite as it has been as per the guidelines and the rules time to time frame, and to eliminate the waiting list. To have the proper eye bank, the All India Institute has a national eye bank, which is one of the pioneer eye bank in our country and doing wonderful job. In addition to the LVEPI and so many other big eye banks are now in our country. And see, to have there are standards are framed in the Human Organ Transplant Act, that what all minimum infrastructures you require, the staff is required. I am not going into the details of those things. But you have the different types of the cornea transportation and preservative media. The most common which we have been using, and still it is to some extent, is the moist chamber. I remember in 1977-78 we used to have a thermos flask with the small bottle, and that cap was perforated, the cotton was placed there, going collecting cornea in the midnight and operating immediately, because we didn't had access to the MK media and now the cornisol. These are the cornisol, the intermediate media, and you can have the good from 7 to 12 days depending upon the type of cornea, environment and before death, how it was taken care of. All who can be the eye donor, people of any age, extreme age we are not taking. Spectacle users, yes, no restrictions. Eye surgery patients, it is quite okay. Diabetes, hypertensive, I take Namrata and I get 4 minutes extra. Now, contraindications for corneal transplant: death associated or due to fulminating viral, bacterial, fungal infections, rabies, hepatitis. Then you have the different all conditions. It is as mentioned here: hematopoietic disorders, local malignancies involving orbit, PNS and adnexa, and death due to the unknown causes, where we should not take it. A long standing on the ventilator is also recommended not to take, because those corneas may not be viable. It's very simple procedure. It takes less than 20 minutes, does not delay funeral arrangements or disfigure the face. Eyes can be removed within 6 to 8 hours of the time of the death. And these are the taboos which is restricting the eye donation activities in our country. But no religious so far debar donating the eyes. And it is a message: don't burn or bury the eyes of your near and dearest one. Post-demise eye donation may bring light in the life of 4 blind persons. How it is 4 now, Namrata has already mentioned. You can have the penetrating keratoplasty, you can have the DSEC, you can have the DMAC, you have the limbal rings which can have the multiple lenticules, and even more than 4 blind persons can be given the vision here. Other than that, the sclera can be used for the other therapeutic purpose, like in the trabeculectomy. If the bleb is having the problem, you can have the patch graft. In the glaucoma, that valve surgery, it for the perforations, etc. Sclera can be preserved for years together in a glycerol or absolute alcohol. So the eye donation is very, very precious and important field of our activities as an ophthalmologist. Whether you are practicing VR, whether oculoplasty, we have the commitment to the country and society, so we must promote it. Thank you very much.
Thank you, sir. Any question on this? Because this is something which is, you don't get many things in the textbooks. So thank you, sir. Thanks.
There are 2 issues after my talk. One, they have to get the certificate, then they have to get the lunch, and they have to ensure that they are sitting to watch the World Cup. So that's why they are not asking questions. Thank you very much.
Thank you, sir. So this session, we conclude the session now, and I would like to invite Dr. Bhalla to please come up and chair the session.
No. There is one more important lecture, medical legal cases.
Dr. Bhalla is the secretary of DOS.
अभी
So now we come to the last talk of this DOS teaching program, and this is very important topic, medical legal cases in ophthalmology, and this will be presented by Dr. Pankaj Vashne, who's a known authority in medical legal field, and he constantly keeps on advising in our DOS executive also, and all the DOS members can avail his expertise whenever they have faced this problem of medical legal cases. Dr. Pankaj Vashne, please.
So good afternoon, everybody. After passing your MD or MS, you will be in practice or in job, and at that time you may need me or any of the advocate or other persons. So better be ready before that. Supreme Court introduced Consumer Protection Act on doctors on 13th November 1995 in a case IMA versus VP Shanta and others. And because this has been included, so now we have to take precautions to prevent risk of litigation. One thing is certain, doctors are not above law. Everybody has to face law, and ignorance of law is no excuse. This is written in books. In negligence cases of medical field, judges are not trained, so they need expert opinion. So first one and the most important thing is, if you have any case against you, you have to ask the court to call an expert in that field. Section 304 is culpable homicide not amounting to murder. It has two parts, part 1 and 2. Acts done with intention to cause death, and acts done with knowledge that it will likely to cause death, but without intention. Section 304A is the section which is mostly applicable on doctors. It is causing death by negligence, death by rash or negligent act not amounting to murder. There are different types of law: criminal law, civil law, Consumer Protection Act and others. Consumer Protection Act was enacted for protection of interests of consumers to have simple and speedy redressal. Now you should know the 4 levels of prevention for yourself. Level 1 primary is that you should prevent from complaint being filed against you. Second is, if a complaint is filed, you should not be held negligent. And third, if you are held negligent and you have been punished, you should have financial compensation. And fourth is to avoid stress of litigation. In level 1, to avoid avoid the complaint being filed against you, you should have proper behavior, social element, doctor-patient communication and education. You should have behavior, good behavior and moderate behavior with calm face towards your patients and their relatives. Should not have commercial attitude and should not have rough and rude behavior. Social element involves your actions should be visible and palpable. Whatever you are doing, it should be visible to the patient and their relatives. You should not apply any of your habits mindlessly, and on your pad and other outside, true qualifications with experience must be written. And you should know that every patient is a potential litigant. He can file a case against you anytime within 3 years after treatment. And examination of females by male doctors should be as per section 53(2) or CRPC, which involves that it should be in presence of a female attendant or female who should know what you are doing to do. Doctor-patient communication involves that queries must be answered with repeated questions, and should have eye contact with the patient. All clarifications about diagnosis and treatment and bills should be given. Case paper should be prepared. You should not give guarantee of results. You should not pass any casual remarks against your colleague, and you should educate the patient about your limitations and other things which you know. Secondary level of prevention involves reasonable skill and care, proper documentation and legally valid consent. Reasonable skill and care involves exercising reasonable skill and care in diagnosis and treatment, because if it is not there, it is medical negligence. Negligence is defined as an act of commission or omission, and it is defined by Bolam test. Bolam case was heard in 1957 in UK court, and after that definition of negligence was framed. It says that failure to act in accordance with standards of average prudent medical man with equivalent qualification and experiences in similar circumstances. That means doing something which a doctor of average prudence does not do, or not doing something which a doctor of average prudence do. These are the things in your favor: proximity of injury, voluntary not fit injuria, contributory negligence, audit guideline protocols, and vicarious liability. Against you are res ipsa loquitur, that means thing speaks for itself. Leaving instrument or gauze piece in the surgical wound, no or invalid consent, incomplete investigations, drug interactions, going beyond skill and qualifications, not taking routine precautions like not doing blood sugar, ECG, etc. before cataract surgery, unethical acts and advertisements. Burden of proof is always on the complainant. It is the complainant who has to prove the case. Suppose you have a case against you by a patient, you should not reply anything unless and until he proves it. If you receive any notice by court or police officer, you have to write only one line, prove it. Okay? 99% of the patients are unable to prove, but if you give any explanation, that will be taken against you. But if you put some defense, you have to prove it. And allegations, when are presented before you, you have to deny each allegation separately, number 1, number 2, number 3, number 4. And do not accept any mistake even if you have done it. No negligence for morbidity or mortality per se, textbook complications like endophthalmitis, error of judgment and using one of the accepted methods. These are the levels of negligence: slight neglect, ordinary neglect and gross neglect. There is no criminal case against you unless negligence is grossly rash or you have mens rea. Mens rea is your intention to do something. This is the most important thing. Records, records and records. It is a rescue to the doctors and it is taken as an evidence in courts. All the records like OPD, IPD, etc. should be kept. IPD records should be comprehensive and chronological in numbered sheets. In case sheets should be numbered 1, 2, 3, 4, and you have to write day and time also. If you have given any instruction to staff, it should be noted down. Handwriting should not have cuttings or overwritings. If you have to delete something, delete it, sign it and date it. All the prognosis and referral should be in writing with signatures. If a patient asks for copies of the records, it should be given to him and have receipt of it. You should not say that the records are misplaced, or you should not suppress anything. If you are transferring a patient, options should be given to him. Do you want to go to a government hospital or higher center, which higher center? And erring patients should be noted. Preservation of records as per law, CP Act says that 2 years. Law of court says that 3 years, which is under Limitation Act. Limitation Act is very important, I will come to it. Biomedical Waste Act says that it should be for 5 years. Income Tax Act says it should be for 8 years. OPD paper should be preserved as per MCI or NMC 3 years, IPD for 5 years, MLC for 10 years or till final disposal of the case. And for all newborn cases, it should be 3 years after the attaining majority age of 18 years. Because limitation period is 3 years and patient will become adult at the age of 18 years. So 18 plus 3 is the time till you should keep records with you. consent should be legally valid. What is consent? When two persons agree on the same thing in the same sense, it protects liability, and there is no total community against negligence for consent. If you have done something wrong, that it will be a negligence. It should be in the same ink, no fixed format, and if a patient denies consent, it should be recorded. Adults are 18 years of age and above as per Indian Contract Act, and 12 years and above as per Section 90 of IPC. Consents can be implied or express. Express can be oral or written. Express written consent should be taken in all these cases. What is informed consent? When doctor gives all relevant information of the deceased, doctor, not staff. Okay? It is doctor. Doctor has to take the informed consent. If you are operating, any doctor of your team can take the consent, but not your staff nurse or anybody else. Doctor gives all relevant information of the disease and treatment to the patients in a language he can understand about benefit of treatment, risk of treatment, alternative treatment available. If he does not get the treatment, no treatment risk, and documentation with patient, doctor and witness signature. And witness should be ideally a third party, not relative of the patient. Because if case goes into court, you say that you have taken consent, patient says you have not taken consent, then court will be dependent on witness. Whatever witness says will be taken. And if witness is relative of the patient, he will speak what the patient is saying. So, to avoid disaster, witness should never be relative of the patient. Consent is not required in these cases. Third is financial consequences like indemnity, insurance and other things. Asset protection plan, if say the number of, as soon as you start your practice, you should have an account, separate account in which you should give 10% of your income every month for your use if a case is filed against you. This is corpus account for you. Now, if you have a case against you, how to avoid stress? Should not be angry or panicky. Prepare the defense by yourself. Does not leave it on lawyer alone. You have to prepare it yourself. Have peer support from societies or your colleagues, and you should avoid media trial. If you lose the case, gracefully accept it, rebuild the practice or consult experts. File an appeal for better defense. If you win the case, don't jump with joy. Introspect why you got a case against you. Compensate for loss of time and money and practice. Learn from the case and educate others about it. Now, few important cases. R. Raheja versus Maharashtra Medical Council. In this, Bombay High Court says that it is duty of the hospital to furnish case papers to the patients. Duty of the hospital, not duty of the doctors. Okay. So it is the hospital who has to provide case reports. SS Iyer versus Triveni Nursing Home. National Commission says that without an expert in medical field, no case can be tried by anybody, even by medical council. Calcutta Medical Research Institute versus Bimlesh Chatterjee. National Commission says that it is the complainant who has to prove the deficiency, not doctor has to give explanation. As per basic law, it is the complainant who has to prove his case, except in case of rape, adulteration and fake currency. In these three cases, defendant has to give his defense. But in all other cases, it is the complainant who has to prove it. In Shantaben Patel versus Breach Candy Hospital, National Commission says that doctors have to take risks. Accidents cannot always be avoided, and every operation have inherent risks. So these cases have to be written while you are preparing your defense. This is very important case, Jacob Matthews versus State of Punjab, in which Supreme Court says that number one, courts have to obtain medical expert opinion. Again, expert opinion is required, and police cannot arrest any doctor in a routine manner without permission or opinion from government or medical council. In Samira Kohli versus Prabha Manchanda case, Supreme Court gives decision in favor of the doctor even though there was no consent. There was no written consent in this case, but court asked the relative of the patient, when the patient was being operated, did you make any noise? They said no. Then for 7 days you were going to the doctor, did you file any police complaint? They said no. Then why on 8th day you filed a case that surgery was done without consent? It means your intention for consent was there. In Shamlal versus Dr. O.P. Nayak, National Commission says that endophthalmitis is a known complication of cataract surgery, and a surgeon who does not have endophthalmitis is the one who does not operate. So endophthalmitis is not taken as negligence. In Dr. S.K. Junjunwala versus Dr. Dhanvantri Kumar, Supreme Court, in Supreme Court, patient failed to prove negligence, so case was dismissed. So patient has to prove the case, not the doctor has to give defense. In Aruna versus Mukund, again Supreme Court says that no complaint against a doctor can be entertained by any court without expert medical opinion. Thank you. Any questions?
Thank you. I think any questions from anyone for Dr. Pankaj Vashne? Dr. Pankaj, just two brief questions. One is, I recently had a case sent by court for second opinion in a posterior polar cataract which was operated at one center. Probably there was nothing recorded on the records, but probably they had the posterior capsular rent, which is a known complication. Lens was implanted in the sulcus. Post-operatively, patient had with minus 4.56 by 6 vision. Somehow, I don't know what happened, patient went to a second center after 4 months. There the doctor wrote on the prescription slip, lens slightly decentered and lens implanted in the sulcus, and the patient was told that a wrong lens has been implanted, although patient did not have any complaint. Now patient has filed a case and the case has come for second opinion. So what do you think should be done in such cases where what deficiency I could find was that there was nothing written on the first case sheet that complication had occurred. What in the post-op it was written was BCVA with minus 4.56 by 6. So
actually, basic law has to be taken. Basic law says that there is a duty of the doctor towards the patient that has to be, that is breached. So duty of the doctor has not been breached. Second is, patient has suffered some damage because of this. Patient has not suffered any damage because he is 6 by 6. So he is unable to file any complaint. Third is, patient has to prove that it was posterior polar cataract and doctor could not diagnose it. Second opinion doctor has written so many things. Might have written, that is called, that I have already said, one should not say anything against any of your colleagues. But he has said, no problem. The third is, you have to call an expert. And when you call an expert in court of law, before expert speaks even a single word, you have to take permission of the court to question the expert. If you have not taken permission of the court before expert is on reply, you cannot question him and his opinion will be taken. So when expert is called in court of law, you have to meet him personally, and usually experts are from higher centers like RP Center and Guru Nanak Eye Center in Delhi, and in other states also they are from medical colleges. They know what the actual situation is. So this case has no value in consumer court and can be easily wiped off.
But only one thing which remains is the complaint that wrong lens has been implanted, because now
wrong lens
minus 4.5 power of the lens, because
that
maybe the same lens which was calculated for in the bag has been implanted in the ciliary sulcus, and
No
maybe they had
no
surgeon
problem.
had,
No
targeted
problem.
myeloma.
Again, the patient has not suffered any damage. He is 6/6.
So no case is made.
So no case can be made because he has not suffered any damage. First thing is breach of duty. Second thing is damage. If anybody has suffered any damage, only then he can call for consumer court case. Otherwise, he is not eligible to file any case. If he files that, it can be easily wiped off.
And
In
say-
Maharashtra, I will give one example. In Maharashtra, one lady eye surgeon treated a case and endophthalmitis occurred. She treated with intravitreal injections, antibiotic and other things. Then the case goes to Maharashtra Medical Council. And I have no hesitation to say that Maharashtra Medical Council President, who himself was ophthalmologist, he wrote that it is a clear-cut case of negligence as no retina surgeon was consulted, or she was not referred to a retina consultant. As the case and Maharashtra Medical Council President has written it, so criminal case was filed against the doctor. Ultimately, that case came to me for opinion. I advised one thing, and that advice went through very easily. I said that there is no retina surgeon in Maharashtra, and there are only few retina surgeons, 5 or 6 in India. There is no retina surgeon. Then when question was asked from me, there are so many retina surgeons in RP Center, Guru Nanak Eye Center, and there are so many fellows from Shankar Netralaya and this. I said that Medical Council has clearly written in its ethics that anyone who is specialized in a field should have Medical Council of India recognized degree on that field. And all these retina surgeons have fellowships. They don't have any retina surgeon degree from Medical Council of India, recognized by Medical Council of India. And there is only one medical college, PGI Chandigarh, who is giving MCH in retina surgery. So all those who are passed their MCH from PGI, only they are retina surgeon in India as per law. In Maharashtra, there is no one. And second thing, in curriculum of MS ophthalmology, clearly in curriculum it is written that how to treat endophthalmitis. So whatever is given in curriculum is accepted. The surgeon who has taken the degree of MS ophthalmology is qualified to do retina this treatment because she knows how to treat endophthalmitis. So she could have this criminal case wiped off from Supreme Court.
Thank you, Dr. Pankaj Washne, for clarifying this very common queries and problems which we encounter. I think with that we come to the end of the session and teaching program, and I'll request Dr. Rohit to say a few words.
Thank you everybody for staying on till the end. It's been 3 hard and difficult days, I'm sure, for you to sit through. It was definitely difficult for me to sit through 3 days, but I must thank the faculty who has taken out time even on a Sunday to be here, and of course from their busy days on Friday and Saturday to take these excellent topics and lectures. We'll be open to any feedback. You can mail us and inform us if there's anything you felt was shortcoming, and we can probably improve next time. Of course, I want to thank our major sponsors, NRI, who have helped us to run this program, without which of course it would not be possible. A personal thanks to the Delhi Ophthalmological Society that entrusted us with this responsibility to hold this DOS teaching program, the President Dr. Rajendra Prasad, the Secretary Dr. Bhalla, the Treasurer Dr. Alkesh. All of them were solid in their support for conduct of this program. I also wish to thank the entire team at RP Center, right from Chief RP Center, who took out time, who spent so much time with you and enlightened all of us. and of course the entire team, right down from all the faculty members, particularly Dr. Praful Maharana, who really worked hard to put this and stitch this program together. Dr. Anu, who's been here with you for the 3 days, ensuring that everything works. And of course, a lot of other faculty members who, in their bits, ensured that the subspecialty is followed and is managed, and the program runs on time. So thank you very much. I'll just request Dr. Namrata, who is the senior most faculty currently available here today, to just say a few words, and then we'll close and lunch for you then.
So I would, on behalf of Chief RP Center and the entire faculty of RP Center, it is a pleasure to have you here for the last 3 days. I am reminded of the first DOS teaching program, which we called as Dost. It was DOS teaching Dost, and that was a single lecture which was taken by Dr. Pradeep Sharma way back in 2007. I'm sure, Rohit, you remember it. And the whole, this whole hall was completely packed. And that was a 45-minute lecture class on squint. So, and at that time there were no, like Dr. J.K.S. Pariyar sir said, there was no internet to teach us, and squint was a tough subject. So the teaching program started all from there and has percolated to the entire country now. And of course, thanks DOS for always, Dr. RP is not here, but Dr. Bhalla and Dr. Alkesh, for giving the opportunity to RP Center. And thank you all the students and the delegates who've been sitting here for last 3 days, and I hope this was useful. RP Center is open to everybody at any time. Whosoever wants to come or see or observe is most welcome to do so. We have options to do that, and wish you all the best in future. Hope you come out with flying colors in your exams, especially the postgraduates, and also make up your mind what you want to do in future, which specialty you want to take, because fellowship is important for you. I think, did we have a class on career options? Okay. So Praful is the best person actually. He's been to so many places that he knows where to go and when to go, and how to waste little time and then, be at your best. So thank you so much. Thank you, Dr. Pariyar sir, for finishing before time. Thank you.
On behalf of Delhi Ophthalmic Society, we really are very thankful to RP Center for undertaking this very useful and successful DOS teaching program. Dr. Namrata, we still call it DOS teaching program because this is one program which is, I think, seeing the response, tremendous response within a short period of time. We did not have much time to prepare for it, but we had excellent attendance, 212 registrations, even more than that, and 81 talks, and the faculty from everywhere, all the teaching institutions. I think it was a tremendous thing. And on top of that, we had a visit to the wet labs and all those investigation labs courses. So I think it was a very successful program, and I'm sure all the delegates, all the residents have really imbibed from all the subspecialty talks. Thank you once again, everyone.
Let's request Dr. Pariyar, Dr. Namrata to give certificate to the last session, the faculty, please. Certificate.
उस पे ना साइन नहीं हुआ दिया नहीं साइन करके देंगे हमने सोचा इसके ऊपर हो जाएगा डेलीगेट्स को दे दिए फैकल्टी के ना हमारे साइन नहीं हुआ किसी के भी मैं सोच रहा था साइन करके दे दें बच्चों को दे दिया हमने फैकल्टी के नाम साइन करके
सर हमारे सेशन के फोटोग्राफ
फोटोग्राफ्स ऑफ ऑल द फैकल्टी प्लीज बाद में कर देंगे चलो ऐसे कर जो हैं उनको दे देते हैं डॉक्टर बिट्ठी प्लीज
Dr. Asa Singh.
अरे अरे आओ क्या कर रहे हो?
अच्छा प्रोग्राम हुआ है तो स्माइल मत अरे एक फोटो और अनु तो आई नहीं स्टार एक फोटो आस्था फिर जाओ ऊपर आगे आ जाओ अनु एक बार और स्माइल करनी पड़ेगी